So in the bonus coverage section, we have a lot of work to do, which we're going to get to. But first, I'd like to talk a little bit about Ted Rosema. When I took this course 2 decades ago, it was chaired by Ted Rosema, and I learned a lot from Ted and from the other teachers in that program. And Ted became a friend and a mentor. And when I had a problem, I would call up Ted, and he would help me solve it. Ted passed away recently, but not until the trial to assess chelation therapy had been published. And Ted was really the key driving force underlying the TAC study. And when I took this course 20 years ago, Ted said that chelation therapy is a great idea. We're doing the right thing for the right reasons. We want to do it as well as we can. And we're going to decrease the risk of our patients for experiencing cardiovascular disease, cardiovascular events, and kidney compromise. And he predicted that at some point, chelation therapy would become FDA approved, covered by Medicare, covered by insurance, and in the hands of every American physician. And he predicted it would take 20 years because we have to overcome the resistance of the medical community that views chelation therapy as a threat. And we aren't interested in compromising their incomes. We are interested in decreasing the need for dialysis, stent placement, hospitalization, and cardiovascular disease. But there's a great deal of resistance from the medical community against chelation because we're going to make people healthy. And Ted predicted that eventually the government would get tired of spending billions of dollars on bypass surgery, stents, and dialysis, where they could spend far less money preventing this disease by covering chelation therapy. So he predicted the TAC study, and so far everything Ted has predicted has come true. And I think within 10 years after TAC2 comes out, there'll be more money for research, and eventually chelation will be FDA approved, covered by Medicare, and then it will be placed in the hands of every physician in the United States. Now, and then Ted predicted that we'd be a much healthier society. And he had another prediction, and I hope I phrased this correctly. Now, I have friends who are vascular surgeons and heart surgeons. I don't mind these guys replacing stenotic valves or dealing with 99% narrowings. I don't mind that at all. But Ted was not really fond of cardiologists, except for me maybe, and cardiovascular surgeons. So Ted said that eventually chelation therapy would be FDA approved in the hands of every primary care physician in the United States. There'd be much less heart disease than in the past. And then, as Ted said, heart surgeons would be forced to retrain as general surgeons and hope for more accidents on the highway. And that's what Ted said. It's kind of a cute phrase. So with that, let's move. We will begin the bonus coverage section with a discussion of antioxidant support. We're going to cover the use of exogenous antioxidants to scarf up free existent free radicals and the use of NRF2 translocators to increase transcription of our antioxidant and detox enzymes to make us better able to manage the oxidative burden that is experienced by modern man. Every 2 years, I take the American College of Cardiology self-assessment course, allowing me to keep up on what's new in allopathic cardiology and brush up on what's old. And of course, I focus on the sections that cover preventive cardiology. And each time I review the self-assessment course, I'm hoping to see something positive about nutritional supplements. And the American College of Cardiology continues to disappoint me with statements saying that outside of fish oil, there's no evidence that nutritional support is of value in the patient with cardiovascular disease. And of course, that's a statement that does not have a basis in reality. We will cover some of the studies, a few of the studies demonstrating benefit of antioxidant supplementation in the patient with cardiovascular disease. Mother Nature generates superoxide as a byproduct of oxidative metabolism. Thus, she gave us the superoxide dismutase enzymes, cytoplasmic, mitochondrial, and vascular, to detoxify superoxide to hydrogen peroxide. In turn, catalase, glutathione peroxidase, and the peroxyredoxins will detoxify peroxide further to oxygen and water. Now, many of our patients harbor antioxidant enzymes that are hypofunctional. They're downregulated. They are not adept at neutralizing superoxide or hydrogen peroxide. And this was not maladaptive for primitive man. Primitive man was not exposed to undue oxidative stress. Primitive man died of infection. And those of us who were not good at breaking down superoxide had more superoxide on board to kill microbes. So these genes were adaptive in in the situation of primitive man, and we're conserved. Many of our patients harbor these downregulations, which are maladaptive in the situation of modern man, where we're being pummeled with free radicals. If you carry out this genomic testing in your patients, you'll see that many of them with cardiovascular disease and other chronic degenerative diseases that are driven by oxidative stress harbor these downregulations. That's why they're our patients. These individuals, the more genomic downregulations you have for your antioxidant defenses, the more likely you are to be the canary in the oxidative coal mine. Now, whether these enzymes are functional or hypofunctional, as a general rule, more is better. Thus, we can supplement our patients with NRF2 translocators to increase transcription of NRF2, which, as we'll see, transcribes antioxidant and detox enzyme systems. Now, what is NRF2? It's got a horrible name, nuclear factor 2 or erythroid factor 2. It's a cap and collar basic region leucine zip or B-zip transcription factor, in case you want to know that. Now, it's transcribed at a tonic low-level rate with a protein half-life of 15 minutes. In the cytoplasm, NRF2 associates with a molecule called KEAP1, Kelch-like ECH-associated protein 1, that binds it to a ligase, col E3 ligase, that ubiquitinates the complex, and then NRF2 is degraded. So we're making this NRF2 molecule at a low level tonically, and we're degrading it. Thus, if it's degraded, it cannot translocate into the nucleus and bind the antioxidant receptor element and begin to transcribe antioxidant and detox enzymes. Now, when we are exposed to toxins or oxidative stress, the sulfhydryl groups on KEAP1 are oxidized, it releases the ligase, and then NRF2 can translocate to the nucleus, bind the antioxidant receptor element, and begin the transcription of enzymes involved in phase 2 detox, antioxidant defenses, cell repair, cell cycle arrest, apoptosis of senescent cells, and more NRF2 will be transcribed. So when we're experiencing oxidative stress, NRF2 goes to the nucleus, generates antioxidant detox enzymes, and more NRF2, so we can continue to respond to the oxidative stress until it has been neutralized by the antioxidant enzymes transcribed by NRF2. Many toxins will lead to NRF2 translocation because they generate oxidative stress and oxidize the sulfhydryl groups on KEAP, allowing NRF2 to translocate, including organic pollutants and heavy metals. And of course, there's therapeutic NRF2 translocators that we take advantage of clinically, and the most important NRF2 translocator is laminar flow. We develop atherosclerosis at branch points in regions of poor laminar flow and high oscillatory flow. We do not develop lesions along the straight and narrow pathways because these regions are characterized by high laminar flow. We want high laminar flow. We want our patients to exercise so they're generating laminar flow, because that will phosphorylate NRF2, which will enhance its translocation. It will phosphorylate AMP-sensitive protein kinase that sends a signal, burn energy, don't build. So we're not going to generate cholesterol, we're not going to generate triglycerides, we're going to burn things to generate ATP, we're going to decrease activities that generate oxidative stress, and we're going to phosphorylate and thus activate endothelial nitric oxide synthase to make nitric oxide, to provide vasodilatation, and to promote resistance against white cell infiltration into the intima. Now, when NRF2 is translocated via laminar flow or therapeutic NRF2 translocators, we're going to transcribe all the enzyme systems involved in our antioxidant detox defenses, including superoxide dismutase and catalase. All of our suppliers will provide us with supplements designed to promote NRF2 translocation. They will contain agents such as sulforaphane from broccoli extract that looks to the body like it's a poison. It's not, it's a pseudopoison, but NRF2 will translocate and will increase transcription of our antioxidant detox defenses. This particular preparation also provides raw materials to help generate glutathione. Metallothioneин's job in health is to store zinc for when we might become zinc deficient, but it will also bind and promote the excretion of heavy metals such as lead and cadmium. And it has a transcription factor, and another supplement will provide sulforaphane to translocate NRF2 and other molecules that promote the generation of metallothionein, and they will show you that this preparation works, that you can get NRF2 translocation, and then upregulation of the expression of all the NRF2 dependent genes, such as heme oxygenase, glutathionase transferase, and N201, which has to do with reducing oxidized quinones. That makes sense because nearly all of our patients and basically everybody in the Western world were being exposed to more free radicals than Mother Nature intended. Bolstering our antioxidant defenses makes sense, and you really can't go wrong with this approach. And we want lots of superoxide dismutase. We need superoxide dismutase to degrade superoxide. So here we're going to look at 40 subjects, 20 with known coronary disease with an abnormal stress test, 20 healthy controls free of atherosclerosis, and we'll see that the patients with coronary disease, their baseline levels of superoxide dismutase were only half that of the normal controls. With the stress of exercise, superoxide dismutase rises in both groups. It rises more in the healthy controls, and then during recovery, the superoxide dismutase hangs around longer. It returns to baseline in the patient with coronary disease. They have lower levels of superoxide dismutase, perhaps due to genomic downregulations, but more likely because their superoxide dismutase is being used up, dealing with superoxide. There's not that much left. Thus, they have lower levels of superoxide dismutase. They are less able to handle superoxide, more oxidative stress, more lipid oxidation, more endothelial dysfunction, more thickening of their IMT, more lesions, more symptoms, a greater risk of atherosclerotic complications. What can we do about this? Well, we can supplement with exogenous superoxide dismutase. Now, superoxide dismutase will be digested, but in this preparation, it is bound to a molecule of gliadin, rendering it absorbable. The gliadin appears to be inactive and not likely to cause problems in people who are sensitive to gluten or gliadin, although here we would be cautious. Let's see if this preparation works. In theory, it should work. Will it work in practice? 34 French men and women in their early 40s who were at high risk for future cardiovascular disease. They did not have known cardiovascular disease, but as you can see, they had risk factors for cardiovascular disease. 3 years before randomization, all meds were placed on hold and they were provided dietary education. At baseline, you're going to look at antioxidant enzyme levels, lipid values, and you'll obtain a baseline common carotid artery mean IMT. Then you randomize these individuals to receive glicidin, which is the exogenous superoxide dismutase derived from melon bound to a gliadin molecule, 2 capsules a day or placebo, and you're going to follow them for several years. And what you find in the placebo patients, the levels of malondialdehyde, which would reflect oxidation of cell membrane lipids, oxidation of LDL, lipid peroxides, it rises over time as you would expect. Nothing was done to lower their free radical burden, while in the glicidin group, malondialdehyde falls, so you're blocking lipid oxidation. Superoxide dismutase expression increases as you would expect, but not in the placebo patients. Glutathione peroxidase expression increases. Now, we're not giving glutathione peroxidase, we're giving superoxide dismutase. But if you're neutralizing a lot of superoxide, there's less work for glutathione peroxidase to do. Thus, you hold on to your glutathione peroxidase. Whenever we decrease the level of superoxide that we're experiencing, we will see increases in superoxide dismutase, glutathione peroxidase, and catalase. Whenever we are exposed to excessive free radical stress, we will see decreases in superoxide dismutase and glutathione peroxidase. Thus, in the preceding study, the patients with coronary disease had lower levels of expression of superoxide dismutase. They had a higher superoxide burden. Thus, their SOD was being used up. Now, carotid IMT progressed in the placebo patients as you would expect. Typically, healthy people will progress their carotid IMT at 0.01 millimeters a year. In the patients receiving the exogenous superoxide dismutase, there was regression. So far in the literature, if your IMT is regressing, you are free of your risk of a cardiovascular event is low. It's nil because you're actually regressing the propensity to form new plaque. Pomegranate juice. Pomegranate will stimulate peroxidase. Peroxidase is a detox molecule. It deals with organic pollutants, and peroxidase is the antioxidant functional arm of HDL. So if we take in pomegranate, we will upregulate peroxidase and have an antioxidant activity within the HDL particle. So here we're going to take 19 Israelis with high-grade but asymptomatic carotid disease. They had 70-90% narrowings, but as they were not symptomatic and endarterectomy was not felt to be needed, they were 65 to 75 years of age, and they were on medical therapy, roughly 2/3 on a statin, 2/3 on an ACE inhibitor. At baseline, you're going to do a carotid ultrasound looking at peak flow velocity from which you would estimate percent stenosis, and you'll do carotid IMT, which is your propensity to form new plaque, sort of the leading edge of the atherosclerotic process, and lab studies. Then they went to the orchards, got pomegranates, would express the juice, and the active therapy patients received pomegranate juice, 55 cc's per day, and the placebo patients had a placebo drink. And you're going to repeat the labs and ultrasound study periodically. And then you're going to analyze the plaque of 3 subjects who did develop symptoms and thus underwent endarterectomy early during the study. There were no effect on glucose or lipid parameters. Patients are often concerned that the pomegranate juice is sweet, it tastes good, it's going to make your sugar and lipids go up. That was not the case. There is sugar in pomegranate, but there's an awful lot of bioflavonoid, and that improved insulin sensitivity. So with pomegranate juice, glucose and lipids do not rise, but the bioflavonoids did improve endothelial function, and blood pressure did fall over 3 years in the patients drinking pomegranate juice, 55 cc's every day. Serum peroxidase, which is the antioxidant principle of HDL, increased. And then they looked at in vitro LDL oxidation, and the rate of basal or copper-induced LDL oxidation was blunted. So the pomegranate is providing an antioxidant effect in the serum, and it's bolstering the defenses of the LDL particle to resist oxidation. Now, our LDLs contain coenzyme Q. They contain typically 5 molecules of vitamin E, helping them resist oxidation. If we bolster the antioxidant levels in the LDL, they become resistant to oxidation, which would be biochemically desirable. 3 of the patients developed symptoms required endarterectomy. In the 2 patients that were on pomegranate, there was lower levels of lesional cholesterol, lipid peroxides, so the antioxidant effect is occurring not just in the serum, not just in the LDL, but within the artery wall itself. There were greater preservation of intimol glutathione and less evidence of LDL oxidation within the plaque. Carotid IMT progressed over 1 year. With the placebo patients, you're supposed to progress at 0.01 milliliters per year. That's in healthy people. These individuals obviously weren't healthy. They were older, they had atherosclerosis, and they progressed 10 times greater than that of normal healthy people, from 1.52 to 1.65 millimeters. Conversely, in the patients that were randomized to pomegranate, you see this prominent regression of IMT. I've read 100 papers on IMT, and I've never seen a study where an intervention has such a powerful effect. And if we're regressing IMT, that doesn't mean we're going to melt away the plaque, but it means we're not going to form new plaque, we're going to stabilize the plaque, and we're at much lower risk of an adverse event. So carotid IMT fell with pomegranate, and the peak systolic velocity and diastolic velocities fell, thus percent stenosis fell. So with pomegranate, you're improving biochemistry in the LDL, in the circulation, within the plaque, you're improving IMT. They didn't look at endothelial function, but if they did, it would have improved, and percent stenosis decreased. So there was an overt anti-atherosclerotic effect. The gains were maintained at 3 years. This seems like a good idea. Pomegranate juice and inducible ischemia. 45 patients with stable coronary disease, abnormal stress studies. You do a baseline stress study, randomize them to receive pomegranate juice, 240 cc's a day, or a placebo juice, a sports drink with similar caloric content, but no pomegranate. You repeat the stress perfusion study at 3 months. Double-blind protocol was followed. Angina frequency increased with placebo therapy. It decreased with pomegranate. Stress-induced ischemia worsened over 3 months with placebo therapy. It decreased with pomegranate juice. So with pomegranate, you're decreasing angina frequency and you're improving perfusion as assessed by an improved stress perfusion study. There are many causes of oxidative stress, many different forms of free radical exposure, and we need a comprehensive integrated antioxidant defense system. one thing that bothers me is the patient will come in with this direct mail newsletter saying that all they need to do is drink this fruit juice from the South Pacific, they're going to be fine. Well, that fruit juice will contain bioflavonoids, which are kind of like middle linebackers and safeties of our antioxidant defense systems, but they don't provide coenzyme Q, they don't provide selenium, etc. So we need a comprehensive antioxidant approach. You could take 1,000 milligrams of coenzyme Q, and that's well and good, but if you have no selenium or no zinc to support catalase and superoxide dismutase, there's going to be holes in your defenses and the free radicals will break through. So this is why we do nutritional testing and make sure that our patients are replete in all the key antioxidants. So it's a team effect, and I like to use this football team analogy. And we need to do this because we can't allow any free radical stress to break through, or we're going to get lipid oxidation. As levels of oxidized LDL rise, we see a progressive rise in CROD IMT. The relative risk for a cardiovascular event will rise when you go from the first to the second or third terciles for cholesterol LDL. It'll skyrocket as oxidized LDL rises because oxidized LDL is the key driving force underlying atherosclerosis. Now, cardiologists will say that antioxidants don't work because clinical trials have not shown a benefit. Indeed, there have been some studies that did not show a benefit of antioxidant support, and there have been studies that show profound benefit, which we'll review. Some of the studies that did not demonstrate a beneficial effect of antioxidant support, in retrospect, were poorly constructed studies. I'm not going to be retrospectively critical of the researchers because a study conceived 25 years ago was based upon our understanding of antioxidant defenses and antioxidant support at that time, not our current understanding. If we're going to give an antioxidant, the goal is to blunt lipid oxidation. In many of these studies, they didn't even measure lipid oxidation. They just picked a fixed dose of an antioxidant to see what effect it would have. And that would be like if we have a new lipid-lowering agent or a new antihypertensive agent, that we would do a study with a low starter dose of the agent. We would not measure the effect of the agent on blood pressure or cholesterol respectively, and then we would see what effect it would have on outcome. If we give a low dose of an antihypertensive agent and it doesn't really lower hypertension, we would not conclude that that agent has no effect on outcome. We would logically conclude, gee, they didn't give enough of the agent to get the job done. So how much antioxidant support is needed? Enough to quell oxidative stress. Some of the studies used just 75 units of vitamin E. Is that enough? Well, our LDLs under ideal circumstances contain vitamin E, but in our patients who are experiencing oxidative stress, there's probably not much vitamin E in their LDL. So in vitro, we can measure how easy it is to oxidize LDL in an in vitro situation. Often you can look at the basal level of LDL oxidation or how quickly or how slowly LDL will oxidize when incubated with copper. And you can see that vitamin E at low doses has no benefit at all. You need to get to 225 or ideally 1200 to really delay LDL oxidation. So if we give a low dose of one antioxidant and we don't measure the biological endpoint, that study doesn't really make any sense. And why are we giving only one antioxidant by itself? We know that there's this teamwork approach. True, E and C will support one another, but they also have different functions and they will work together. In this study, we're looking at the effect of E or C or combination supplementation in decreasing the rate of IMT progression. And vitamin E alone blunted IMT progression by 5%, C alone by 5%, E and C working together to interact and support one another blunted IMT progression by 45%. And if you'd included selenium and zinc and coenzyme Q, you would have gotten a better degree of protection against IMT progression. Now, E and C in non-smokers did not have the same relative effect as did E and C in smokers. Why? Because the smokers have a greater oxidative burden and they have a greater upside potential with supplementation. Now, in the TAC study, in the diabetic group, chelation therapy had a stronger effect than in the non-diabetics, as did antioxidant supplementation. Why? Because the diabetics are experiencing greater baseline oxidative stress than non-diabetics. Diabetes leads to oxidative stress. Thus, this tremendous synergy between chelation and antioxidant vitamins in improving outcome. And within the TAC study, we used the standard ACAM protocol. The fathers of ACAM had this figured out many decades ago, a balanced antioxidant vitamin mineral defense system. There's studies basically of every one of these nutrients showing that they will help all by themselves. Why not put them all together? There's no downside here. Now, the cardiologists who said that antioxidants did not have any value were rendered into a state of chaos with the Cambridge Heart Antioxidant Study that was published in Lancet about 10 to 15 years ago. Lancet is the most widely read medical journal in the world, but perhaps not by physicians who are members of the American College of Cardiology. Anyways, just over 2,000 men and women with newly diagnosed significant coronary disease. Angiograms were abnormal in all, 3-vessel or left main disease in 38%, moderate to severe pump dysfunction 25%, 90% had angina or an abnormal stress test, none with prior vitamin E use. So you diagnose their new onset significant coronary disease, and following angiography, you randomize them to placebo or to vitamin E. 1,035 got 800 units, 546 got 400 units. You're going to follow them for 510 days. All standard therapies permitted. A similar percentage of the patients required revascularization, and the study endpoints were non-fatal MI, and cardiovascular death, and double-blind protocol was followed. So will vitamin E at 400 or 800 have a beneficial effect on outcome in these individuals with newly diagnosed coronary disease? Now, there was no effect of vitamin E on cholesterol, but of course, the point of vitamin E is not to lower cholesterol. The point of vitamin E supplementation is to provide an antioxidant defense, and they used alpha tocopherol, not mixed tocopherols, but alpha tocopherol, and with treatment, the alpha tocopherol level rose. As you'd expect, it did not rise with placebo. Now, over the follow-up period, there were 55 non-fatal heart attacks. Vitamin E supplementation decreased heart attack risk by 77%. And you'll notice that the vitamin E 400 group had fewer heart attacks than the vitamin E 800 group, who had far fewer heart attacks than those subjects assigned to placebo therapy. 50 cardiovascular deaths. Vitamin E did not decrease overall cardiovascular death rate. 105 major cardiovascular events. Vitamin E decreased major cardiovascular event risk by 47%. Again, E400 worked better than E800. Well, why is that? Because this was alpha tocopherol, not mixed tocopherols. When we supplement with alpha tocopherol at a high dose, we will block absorption of beta, gamma, and delta tocopherol. The only way to hurt our patient with nutritional intervention is to flood the system with a single molecule that will block absorption of its colleague molecules or draw other antioxidants into a pathway that is being upregulated. So why we use alpha tocopherol for vitamin E and not mixed tocopherols is a big mistake. And that's a mistake that you're not going to make. And all of our suppliers now understand this, and they provide mixed tocopherols. So the problem here was when you give 800 of alpha tocopherol, you'll render the patient deficient in beta, gamma, delta tocopherol. They all have distinct roles. Thus, 400 worked better than 800. This was brain-in-the-box nutritional medicine. Now, I'm not going to fault these researchers because they did not understand this principle when they conceived the study. We do understand this principle, and we're going to utilize a balanced antioxidant support system so we do not create any relative nutritional deficiencies. But even alpha tocopherol all by itself was beneficial versus placebo, significantly decreasing major cardiovascular event risk by up to 47%. Will vitamin E decrease stroke risks when provided to patients who have experienced a TIA? This study looked at 100 subjects with TIAs, minor incomplete strokes, retinal strokes, TIAs, all at risk for a further ischemic event. These events involve abnormal blood platelet function. There's platelet aggregation, there's a post-aggregation free radical oxidative burst, platelet adhesion of the vascular wall. While aspirin blunts platelet aggregation, vitamin E would blunt the oxidative burst, and vitamin E blunts platelet adhesion. Thus, we would anticipate synergy between aspirin and vitamin E. So we took these 100 patients, and they were randomized to receive aspirin, 325 milligrams a day, or aspirin plus vitamin E, 400 IUs a day. You're going to follow the patients over 2 years until an event occurred, and the hard endpoints that were followed for were stroke, recurrent TIA, other cardiovascular events, or a hemorrhagic event, just to make sure that vitamin E did not increase bleeding risk associated with aspirin. And what they find, total events at 2 years falls from 40% with aspirin monotherapy to 27% when we combine aspirin, an antiplatelet agent, with vitamin E and antioxidant. Stroke risk falls from 13% to 6%. TIAs fall. There was no increase in bleeding, no change in cardiovascular event rate. The SPACE study, secondary prevention with antioxidants in end-stage renal disease, like diabetics, patients with renal failure, particularly patients with renal failure on dialysis, are experiencing an inordinate level of oxidative stress. Thus, would antioxidant supplementation help? 196 dialysis patients with known cardiovascular disease, a sick group, all experiencing high levels of oxidative stress, randomized to vitamin 800 or placebo. You're going to record from hospital records over a 2-year period. Primary endpoint, heart attack, stroke, or new peripheral vascular disease. Secondary outcomes was component outcomes and mortality. Randomized, double-blind, multi-center study. So the primary endpoint, heart attack, stroke, or new peripheral vascular disease, fell 54%. 33% of the subjects on placebo, 15% of the subjects on vitamin E. Here we have event-free survival, which is improved with vitamin E supplementation. Heart attack risk, 17% to 5%, 70% risk reduction, unstable angina, 50% reduction. So in this group, vitamin E certainly worked well. Cardiovascular death falls by 39%. New onset peripheral vascular disease falls by 61%. Oxidative stress characterizes atherosclerosis. If we look at malondialdehyde, a marker of lipid cell membrane oxidation, LDL oxidation, we see that it's not that high, it's not higher in patients with stable angina than in healthy controls, but it skyrockets in unstable angina because oxidative stress will produce plaque activation. Plaque activation will induce more inflammation, more oxidative stress. Oxidized LDL, of course, is also greater in patients with heart failure than in healthy controls because heart failure also generates oxidative stress. Oxidative stress will worsen heart failure. The ratio of superoxide to nitric oxide within the myocardium determines the efficiency of contractility. If we have oxidative stress, we have impaired contractility. That will worsen the heart failure. More oxidative stress, more impaired contractility. Vitamin E will it reduce C-reactive protein and interleukin-6, and these are products of nuclear factor kappa beta translocation. We know that peroxide promotes nuclear factor kappa beta translocation. Vitamin E should decrease our peroxide burdens. Would vitamin E blunt nuclear factor kappa beta translocation, lower CRP and interleukin-6? 70 subjects not taking antioxidants, 23 healthy volunteers, 24 type 2 diabetics without known vascular disease, 23 type 2 diabetics with known macrovascular disease. Groups were matched for age, gender, and stature. At baseline, you measure CRP, IL-6, treat all with vitamin E, 1,200 units a day over 3 months, and then repeat the measurements of these inflammatory cytokines. Now, the healthy volunteers were not as healthy as they thought. As a general rule, healthy people in America are simply people that have not yet been diagnosed with cancer, autoimmunity, or cardiovascular disease. We're all waiting to get sick. So these healthy people weren't as healthy as they thought. And with vitamin E, their CRP and IL-6 levels fell. In the diabetics without cardiovascular disease, CRP and IL-6 fell. In the diabetics with known cardiovascular disease, their baseline level of CRP was greater and it fell. Their IL-6 levels was not greater, but it fell. So in all the groups, the normal patients, the diabetics without cardiovascular disease, the diabetics with cardiovascular disease, vitamin E supplementation lowers CRP and IL-6. What would be the effect of antioxidant support on Roberts's rules? Well, if we quell oxidative stress, all of the other effector arms of the atherosclerotic process will be blunted. Aberrancy at any one loci, such as oxidative stress, will adversely affect the other loci. If we correct oxidative stress with supplementation or NRF2 translocators or getting rid of the heavy metals, that'll have a favorable effect on all the other loci and promote overall health. Vitamin C and outcome. This study, this is the San Valentino study, and it was published in abstract form, and it was never published as an intact paper. I don't really know why, but 855 low-risk asymptomatic patients, you baseline carotid and femoral ultrasounds and categorize them as normal vessel, plaque, a moderate less than 50% narrowing, or a greater than 50% narrowing in the femoral or carotid arteries. You randomize them all to receive over 10 years vitamin C 1,000 milligrams a day or placebo. Let's look at 10-year event rate versus baseline ultrasound findings. With placebo therapy, if you were normal, you were at very low risk of having an event at 10 years. As you go from plaque to moderate narrowing to a greater than 50% narrowing, you are at greater risk of having an event. And we would expect if you have a greater than 50% narrowing in your carotid artery, your 10-year event rate ought to be about 82% because you have pre-existing disease. If we intervene with vitamin C, we can see tremendous protection. Now, the normal patients remain normal. They were at low risk. But in the patients with plaque, moderate plaque, or greater than 50% narrowing, there was a tremendous blunting in event rate. So 10-year event rate falls by basically 50%, from 82% to 44% when patients with baseline narrowings above 50% simply take vitamin C. Why? Because vitamin C will squelch superoxide. If we look at endothelial function, we can use something called the cold pressor test. We don't use that much anymore. You put your hands in ice water, causing a sympathetic stress, and you see what effect it has on blood flow in the LAD distribution. If you have poor endothelial tone, blood flow will decrease. And you can see here that one shot of intravenous vitamin C acutely improved endothelial function, but chronic oral vitamin C restored the endothelial function that would be lost with this stress. So vitamin C improves endothelial function. Now, a study carried out in Japan, they took patients who were treated with balloon angioplasty and they received placebo or vitamin C, just I think 250, maybe 500 milligrams twice a day, a small dose, and they repeated their heart caths, and restenosis was blunted. The need for repeat balloon angioplasty fell from 33% to 14%. Another reason that American cardiologists argue against vitamin C, because it's going to decrease restenosis, so we will have fewer procedures to do. If I sound a little bit sarcastic, it is because I'm quite disappointed in the attitude of the American College of Cardiology regarding antioxidant support. We have all these studies showing that it's beneficial. Why do they persist in arguing against it? Why do they persist in arguing against chelation therapy? If you undergo bypass surgery, your risk of experiencing atrial fib post-op is high, 40%. And studies done at the Cleveland Clinic and at the DeBakey Institute show that pre-treatment with vitamin C going into bypass surgery decreases your risk of post-CABG atrial fib from 33% to 14%. At these institutions, will you be treated with vitamin C? Absolutely not. They will tell you to stop taking all your vitamins because they're potentially toxic. They did the study, showed that it worked, but they refused to recognize this. As a matter of fact, in one of the cardiology journals, there was this sarcastic editorial to the effect like, well, what should we do next? Just tell them to drink orange juice? As if it is beneath us for our patients to take antioxidants and other nutritional supplements that improve outcome. If you get a cardioversion, you're likely to return to atrial fib within a week, because if we don't do anything to alter your biology and physiology, why wouldn't you go back to atrial fib? When this study, they took patients undergoing cardioversion. One group received vitamin C, the other group received placebo. Recurrent fib was 40% with controls, 5% with vitamin C. Oxidative stress plays a role in atrial fib. When we talked about colchicine, we showed how colchicine decreases the risk of recurrent fib following ablation, and the efficacy of colchicine related to the ability of colchicine to decrease the generation of inflammatory cytokines. So atrial fib is not all about anatomy. Anatomy plays a role, but physiology, oxidative inflammatory stress plays a role, and vitamin C will blunt one's risk of atrial fib with bypass surgery and recurrent fib following cardioversion. So there's legions of benefits of vitamin C in cardiovascular disease. This slide is about 15 years old. I really haven't looked at the literature since then, and I don't need to because I know vitamin C is a good idea. In a reductive environment, Nitric oxide synthase converts arginine to nitric oxide to upregulate cyclic GMP, which provides the vasodilatory effects of nitric oxide, the antiplatelet effects, to decrease NLRP3, which would activate caspase to convert nascent interleukin-1 beta and interleukin 18 to their active forms, and it supports ICBA to prevent nuclear factor kappa beta translocation. If we generate more nitric oxide than we need at any given moment, we will react it to thiol-bearing agents such as glutathione and cysteine as a ready reserve. So we depend upon a reductive environment with excessive available thiol groups to optimize nitric oxide synthase activity and endothelial tone. So when we have oxidative stress, we often have a depletion in thiol groups such as cysteine or glutathione. Would supplementation be of value? Here, let's look at 134 patients on dialysis for end-stage renal disease. Again, this is a group that would be experiencing a great deal of oxidative stress. 12 with prior balloon angioplasty, 18 with prior bypass, none on antioxidants. Randomized to receive N-acetylcysteine, 600 milligrams twice a day. N-acetylcysteine provides thiol groups and it supports glutathione generation. We want lots of cysteine and glutathione within the intima, or placebo BID. You're going to follow them over a mean of 15 months and record. The primary outcome was the composite of heart attack, stroke, cardiovascular death, coronary revascularization, or amputation, or percutaneous intervention for peripheral vascular disease. Secondary outcomes were oxidized LDL levels on treatment. Double-blind protocol was followed. So on treatment, oxidized LDL drops dramatically. This is a good idea. The goal of antioxidant support is to lower lipid oxidation. We lower LDL oxidation tremendously. We would thus anticipate we're going to see a favorable effect on outcome. Well, let's actually measure outcome and find out. Ischemic stroke, 69% reduction. New peripheral vascular disease, 36% reduction. New cardiac event rate, 30% reduction. The primary endpoint, 40% reduction. Here we have event-free survival enhanced with N-acetylcysteine. Just think about it. All the dialysis patients in the United States, if we just gave them N-acetylcysteine, what tremendous benefits would we experience as a society? Sadly, nephrologists, like cardiologists, refuse to recognize the benefit of any non-pharmaceutical support. It's as if we physicians simply want to maintain the dependency. We want the patient to be dependent upon us and our prescription pads. We don't want the patients to be able to independently obtain health-providing nutritional support to decrease their need for us. Let's look at N-acetylcysteine supplementation and the phenomenon of nitrate tolerance. So our patient is experiencing angina, they take a sublingual nitroglycerin, nitrate enters their circulation, it will be converted to nitric oxide, you'll get vasodilatation and relief of angina. Thus, if sublingual nitroglycerin works, why not long-acting nitroglycerin? And these preparations were introduced about 35 to 40 years ago. The initial therapy was nitro paste. And any of you who are my age remember that. You'd have the patient in the ICU experiencing angina, and you'd treat them with nitro paste. And it would come like a tube of toothpaste, and you'd squirt some on a piece of paper and slap it on the patient's back. And then the nitrate would enter their circulation, be converted to nitric oxide, and this was of value in angina and in heart failure. And you had to be really careful not to get any of the nitrate on your fingers, or you'd get a nitrate headache, so you'd wear gloves. So that the nitro paste was difficult to use, and then the manufacturers came out with long-acting oral nitrates such as isosorbide dinitrate or isosorbide mononitrate, which were much easier to use. And we would treat our patients with these long-acting nitrates, and their angina would improve, but then it would return, and we'd have to increase the dose. There was this phenomenon of nitrate tolerance. You had to give more and more of the long-acting nitrate to provide an equivalent therapeutic benefit. We did not understand why this was occurring, because their arteries weren't worsening, but their sensitivity to the long-acting nitrates was being attenuated. And then epidemiologic studies came out showing that long-acting nitrate therapy was a bad sign. People taking long-acting nitrates did not do as well as patients not on such a therapy. So why is this occurring? Why are long-acting nitrates having an adverse effect on outcome? And what is this phenomenon of nitrate tolerance? Well, if we take a long-acting nitrate, we're going to shut down endogenous nitric oxide production. So if we shut down nitric oxide synthase, we're going to quit making nitric oxide, we're going to make more superoxide. In addition, for every molecule of nitrate that is converted to nitroglycerin, we're going to waste glutathione. So long-acting nitrate therapy leads to oxidative stress, leads to endothelial dysfunction, thus you need more and more nitrate and you have an adverse effect on outcome because oxidative stress and endothelial dysfunction are the key drivers of this disease. So thus, long-acting nitrates leads to tolerance of the beneficial effects, worse outcome. Now, N-acetylcysteine provides an antioxidant effect. It's a precursor to glutathione. We want lots of glutathione. We want lots of thiol donors within the intima. Can N-acetylcysteine supplementation improve outcome in nitrate-treated patients? 200 patients with unstable angina, none required urgent revascularization, all treated in the same fashion, aspirin, calcium blockers, beta blockers. Randomize these patients to receive a 10 milligram nitroglycerin patch with placebo, a placebo patch and N-acetylcysteine 600 milligrams a day, a double placebo or double active therapy. Reevaluate at 4 months looking for adverse event, and then you're going to do 24-hour EKGs and sum up the degree of ST depression as a sign of ischemic burden. Randomized double-blind protocol was followed. Ischemic ST depression on the 24-hour EKG, baseline at 4 months fell a little bit from 24% to 15% with placebo. It fell more from 37% to 16% with NAC, 19 to 12% with nitroglycerin, but the best effect was double active therapy, the long-acting nitrate to provide exogenous nitric oxide, and N-acetylcysteine to prevent nitrate tolerance, falls from 25% to 4%. Adverse event rate, revascularization, MI, overall event rate, the best result was with combination therapy. So combination therapy was most effective in relieving ischemia as judged by the 24 EKG and decreasing the risk for an adverse event, revascularization, MI, or the composite. So here we have event-free survival, the best results, nitroglycerin and N-acetylcysteine. Whenever we give a drug, we need to anticipate the nutritional deficiency that occurs as a consequence of the drug. So if we give a diuretic, we all understand we have to pay attention to electrolytes, magnesium, potassium, and B vitamins are washed out as well. When we give a statin, we always are going to use concomitant coenzyme Q. If we give a long-acting nitrate, we can do that and it will help the patient, but it will hurt the patient if we don't provide concomitant antioxidant support. And similar studies have been done showing that nitrate tolerance is abrogated with vitamin C, vitamin E. Here they used N-acetylcysteine, and if you had to pick just one antioxidant to neutralize nitrate tolerance, it would be N-acetylcysteine, or you could do the study again with glutathione administered in an absorbable format. So as part of our integrative approach to oxidative stress, antioxidant support, we've covered some of the studies, and there's many, many more studies showing benefits of individual antioxidants, or particularly a comprehensive program of antioxidants, and the best study of all would be the TAC study, where a comprehensive nutritional support as per the ACAM protocol in combination with chelation therapy, there was a synergy to decrease event rate, particularly in the diabetics. So we're going to use antioxidants, and we're going to recommend NRF2 translocators to tonically increase transcription of our antioxidant and detox enzymes. Again, the American College of Cardiology is not listening to what I'm saying today. They're not reading these articles published in the literature, and they continue to persist with this notion that there's no role for nutritional supplements, and there's no role for nutritional supplements. We want to maintain the population in a position of dependency to us such that individuals cannot take action on their own to optimize their health, and they must be dependent upon us physicians and our prescription pad and our invasive procedures. And of course, that is a statement that has no basis in scientific reality. We take fish oil in an effort to optimize prostaglandin balance. The only dietary essential fatty acid is cis-linoleic acid that we get from vegetable oil. Cis-linoleic acid is converted by delta-6 desaturase to gamma-linoleic acid, which we can obtain as a supplement from evening primrose oil or borage oil, or generate from dietary cis-linoleic acid that is converted to prostaglandins of the 1 series, Cis-linoleic acid, to some degree, can be converted to alpha-linolenic acid and then onto eicosapentaenoic acid, although we rely more on dietary intake than endogenous conversion, and the eicosapentaenoic acid is converted to prostaglandins of the 3 series. 1s and 3s work together to promote vasodilatation, antiplatelet effect, lower inflammation, promote weight loss, and lower cholesterol. Gamma-linoleic acid, obtained from dietary cis-linoleic acid, can be converted by delta 5-desaturase to arachidonic acid, although we get most of this from meat and dairy, and arachidonic acid is converted to prostaglandins of the 2 series or leukotrienes that promote vasoconstriction, platelet aggregation, pain, fever, and inflammation. Now, that's the way where Mother Nature intended us to be in balance with pro-inflammatory and anti-inflammatory prostaglandins and leukotrienes, so we can mount an inflammatory response to a real threat, and then we can recover or repair the consequence of the inflammatory response. The problem is that we're no longer eating as Mother Nature intended. Since 1800, the percentage of our calories that come from fat has increased, and we're taking in the wrong types of fats. We're taking saturated fats, we're taking in trans fats. Now, trans fats are metabolic poisons. They compromise the metabolism of healthy essential fatty acids into the corresponding leukotrienes and prostaglandins. And of the unsaturated fat that we're taking lots of omega-6 and less omega-3. So we're totally out of balance. Too much saturated fat, too much trans fats, too much omega-6, not enough omega-3. So we're out of balance. In addition, our diet and our environment is rich in molecules that block delta 5-desaturase, so the linoleic acid we're getting from our diet is not being converted to gamma-linoleic acid. We're not getting alpha-linoleic or eicosapentaenoic acid. We're not taking in flaxseed oil or walnuts or fish. So we're low in series 1 and 3 prostaglandins. We're getting lots of meat and dairy, a lot of arachidonic acid. So we have an imbalanced situation with unbalanced vasoconstriction, platelet aggregation, blood clotting, pain, inflammation, hyperlipidemia, and difficulty with weight control. We need to rectify this situation, and we can measure the levels of essential fatty acids in our red cell membranes and target our supplementation to optimize the representation of omega-3 and minimize the representation of arachidonic acid. We don't want to wipe it out completely, but we want it to go back into a balance. So dietary vegetable oils, flax oil, walnut oil, fish oil, cut back on red meat and dairy, and vitamins and minerals to optimize the ability of delta 5-desaturase to convert cis-linoleic acid into gamma-linoleic acid to get back into a homeostatic physiology. So what will be the benefits of fish oil supplementation in patients with cardiovascular disease? As a general rule, if you have cardiovascular disease, you suffer from long-term prostaglandin and eicosanoid imbalance because you're not getting enough omega-3, you're getting the wrong type of omega-6, you're out of balance. So if we supplement you with fish oil, we can correct this abnormality, and we should be able to lower risk factors and improve outcome. I haven't really looked at the literature in 10 years, and this slide is thus 10 years old, but there are benefits of fish oil supplementation in patients with cardiovascular disease. HDL rises, triglycerides and LPA may fall, LDL particle size increases, coagulation profile improves, fibrinogen and PI1 fall, homocysteine falls, endothelial function improves, angina frequency and nitroglycerin requirements decrease, you walk farther than the treadmill, your angiographic appearance improves over 2 years, lower risk for an adverse event, less vein graft closure following bypass, restenosis following balloon angioplasties blunted, improved cardiac autonomic function, increased heart rate variability, decrease in ventricular arrhythmia, protection against sudden death, preventive and therapeutic in atrial fib, major reduction in post-heart attack mortality. That was the Indian experiment of infarct survival, and multiple non-cardiovascular benefits, because if you have an eicosanoid imbalance that produces cardiovascular disease, you're going to have an eicosanoid imbalance in every cell of your body, and this will increase your risk for other disease states characterized by undue oxidative and inflammatory stress. Let's look at omega-3s and endothelial function. Endothelial function is the most important predictor of outcome. We depend upon a high level of nitric oxide generation. We don't want nitric oxide synthase instead to make superoxide. 30 hyperlipidemic individuals, so they're going to have endothelial dysfunction, Cholesterol is above 250 with no other risk factors. So pure hyperlipidemia. You measure brachial artery flow-mediated vasodilatation, randomize them to receive over 4 months ethyl ester EPA, 1,000 milligrams twice a day, or placebo. With placebo therapy, there was no significant improvement in flow-mediated vasodilatation. With fish oil, it more than doubled from 5% to 12%. So essential fatty acid supplementation improves endothelial function. In a study looking at anti-clotting effects in healthy controls and in patients, fish oil supplementation decreased PI1 by 21%. PI1 promotes clotting. And again, these healthy people weren't as healthy as they thought they were. They just hadn't yet been diagnosed with the disease. So in the healthy controls, or the people who thought they were healthy, and in the patients with coronary disease, PI1 falls, fibrinogen will fall. And this paper was published in the New England Journal of Medicine about 15 years ago, and that fish oil has an antiplatelet effect similar to that of aspirin. In studies of fish oil supplementation in patients with stable angina frequency decreases, time to ST cycle depression on the treadmill increases by 2 minutes. That's a greater response than you would get with a revascularization procedure. In the Indian experiment in infarct survival, heart attack victims were randomized to placebo, mustard oil, which is kind of like flax oil, or fish oil, and at 28 days, adverse event rate fell from 29% in controls to 16% with fish oil. Sudden death, non-fatal MI, cardiovascular death, total events falls from 35% to 24%. If you carry out a balloon angioplasty and put the patient on fish oil that day, there'll be no effect because fish oils work slowly. They have to work their way into the cell membrane. But if you pre-treat the patients with fish oil for 2 months and then carry out the balloon angioplasty, there will be protection against restenosis. Just as with vitamin C and with magnesium, pre-treatment of patients with the fish oils going into bypass surgery decreases the risk of atrial fib from 33% to 15% and shortens hospital stay. So if all of our patients undergoing bypass surgery take fish oil, you get out of the hospital a day quicker. And this analysis was also done with CoQ, and you get out of the hospital quicker. Essential fatty acids in lupus and atherosclerosis and autoimmunity are both Th1 and Th17 skewed, acquired response of the immune system to what the immune system perceives as infection. In the artery wall, it's oxidized lipids. In individuals with collagen vascular disease, autoimmune disease, it is structures within the periphery that have been altered and they now appear to be foreign. Thus, you mount an immune response against the periphery, against the joints, or against other target organs. So we're going to take 12 patients with newly diagnosed lupus and autoimmune disease, baseline measurements, then treat all with a fish oil capsule to provide 972 milligrams of EPA and 864 milligrams of DHA. Patients with kidney or heart involvement received steroids during months 1 and 2, then steroid therapy was decreased. We're going to reassess at 6 months of essential fatty acid supplementation. So the blue are controls, healthy volunteers, red are the lupus patients, and green are the lupus patients on fish oil supplementation. If we look at the percentage of EPA within the cell membrane, there's no difference between the controls and the lupus patients, but if you supplement the lupus patients with EPA and DHA, EPA rises. DHA is low in the lupus patients, but if you supplement, it rises above that of the healthy controls. Arachidonic acid, which is converted into the deleterious series 2 prostaglandins and inflammatory leukotrienes, is expressed at a higher level in the lupus patients than in the healthy controls, and the percentage of the cell membrane composed of arachidonic acid falls when you supplement with EPA and DHA. Now, you're not actually taking away arachidonic acid, but you're diluting it, you might say, by supplementation with essential fat, with the EPA and the DHA. Lipid peroxides were greater in the patients with lupus. Superoxidismutase was suppressed versus the healthy controls, and this makes sense because this is a disease characterized by oxidative inflammatory stress. So you would expect to have more lipid peroxides and depletion of superoxide dismutase. Now, if you supplement with fish oil, lipid peroxides falls and superoxide dismutase increases. Now, we're not giving superoxide exogenously as we did with glicidin, but by lowering inflammation, we're going to lower the generation of free radicals, because oxidative stress leads to inflammatory stress. Inflammatory stress leads to oxidative stress. By blunting inflammation, we decrease the generation of free radicals. There will be sparing of superoxide dismutase. Lower levels of nitric oxide, because the superoxide is degrading the nitric oxide and shutting off nitric oxide synthase, turning it into a superoxide generator, not a nitric oxide generator. But if you improve endothelial function and lower inflammation oxidative stress with fish oil, nitric oxide levels rise. The same situation with glutathione. So with omega-3, essential fatty acid supplementation, arachidonic acid expression falls and anti-inflammatory omega-3 fatty acid levels rise. Antioxidants are enhanced, lipid peroxides fall, nitric oxide and glutathione levels rise. So how do the patients respond? They all went into remission. These were individuals with new onset lupus. There was not, say, advanced anatomic damage that had been carried out. They were early in the disease. This disease is associated with inflammation oxidative stress. You quell the inflammation oxidative stress with fish oils, and the subjects got better. What would the effect of fish oil be on Roberts's rules? Well, it lowers inflammation, it lowers oxidative stress. Of course, we would expect that all the effector arms of atherosclerosis would be blunted with fish oil supplementation. And outside of the cardiovascular system, there's a great deal of benefit of essential fatty acid supplementation in basically all age-related degenerative conditions, because in common they all are associated with oxidative inflammatory stress. Depression improves. Healing from a duodenal ulcer is enhanced with fish oil supplementation. Fish oils work as well as an antihistamine. This was a really cool study where they looked at graft survival when you underwent kidney transplant to deal with kidney failure on an autoimmune basis. And one group received placebo, one group received fish oil. They held onto their grafts longer and required less repeat surgery or the need for dialysis. So if you ever have a heart biopsy, I want to see something like this, something fishy going on in your heart. This was published in the New England Journal of Medicine, and it was a microscopic slide of an individual who had a heart attack, and the scar looks kind of like a fish. So that was kind of cute. Specific pro-resolving lipid mediators, SPMs. This is a new concept that I don't fully understand, but we pay attention to our essential fatty acid intake because we know that fish oils will be converted into anti-inflammatory prostaglandins, and then meat and dairy contains arachidonic acid that are converted into pro-inflammatory prostaglandins. But above and beyond that, these anti-inflammatory and pro-inflammatory prostaglandins will then be converted into resolvins. When Mother Nature creates an inflammatory response, she anticipates that there may be sequelae that we need to clean up. So pro-inflammatory mediators derived from arachidonic acid after 3 to 4 days will be converted into mediators that promote resolution, and they stimulate macrophages to enter the area of inflammation and gobble up the debris and repair the region of the body in which inflammation is occurring. One of the downs, we know that non-steroidals and COX-2 inhibitors such as Vioxx, their use is associated with an increased risk of cardiovascular disease. And one of the reasons may be that, they knock out the painful prostaglandins, but they're also going to be knocking out the resolvins, and thus you cannot repair from inflammation. And the corollary here would be that you cannot mount a resolving response and generate macrophage infiltration into the artery wall to remove the foam cells and the lipids, so you cannot regress inflammatory atherosclerosis. So the manufacturers have this all figured out, and you can take specific pro-resolving lipid mediators. Now, we want to take fish oils and minimize arachidonic acid, but we can take these pro-resolving mediators, and this will enhance resolution of inflammation. And in the literature, there's a lot of animal research to show that this will be of value, and human research is ongoing. I think this is a good idea, so I'm taking a specific pro-resolving lipid mediator because I think it's a good idea. I also think it's helping me from my aches and pains from sports injuries. So you can, they have these horrible names of the resolving mediators, but you can take these in a gel cap, and this will support Mother Nature's plan to help us resolve and recover from inflammation. Vitamin D is for more than just prevention of rickets. Vitamin D levels are inversely related to the degree of cornea calcification. In this study, there was an inverse relationship between vitamin D and cornea calcification. Low D, more calcification. There was no relationship between LDL cholesterol and calcification. There was a relation between vitamin D. Low D promotes cornea calcification. In patients with familial hypercholesterolemia, the lower your vitamin D, the greater the degree of cornea calcification, the greater the degree of peripheral vascular calcification. When we are low in D, we will have hypocalcemia, and we will have an elaboration of parathyroid hormone. If you read up on parathyroid hormone, this is kind of a bad actor on the cardiovascular system. We do not want high levels of parathyroid hormone. Thus, we want to take vitamin D. We want to have normal calcium homeostasis. We do not want high parathyroid hormone. Vitamin D works with K2 to blunt vascular calcification. Vitamin D is critical for proper immune function. Let's look at vitamin D and cancer prevention. 1,200 healthy, at least 55-year-old Nebraskan women, not getting a whole lot of sun in Nebraska, randomized to a daily program of placebo, calcium carbonate, calcium with vitamin D, just 1,000 units a day. Vitamin D levels were below 30 at baseline. We would like our vitamin D levels to be above 30, preferably 50. No one knows the best level of vitamin D, but these patients were all low in vitamin D. They were all suboptimal. Calcium supplementation does not raise D, but vitamin D supplementation does, from 29 to a physiologically more appropriate level of 38. Parathyroid hormone fell with calcium because you're improving calcium physiology, thus there's less impetus to generate parathyroid hormone, but the best response was calcium and vitamin D with respect to lowering PTH. Then they followed them for 4 years, actually 5 years, and looked at new diagnosis of cancer. 7% in the placebo group, 4% in the calcium group, 3% in the calcium with D group. And here we have cancer-free survival was best with calcium and vitamin D. Relative risk of cancer over 4 years, falls by 50% with calcium, and it falls by 60% with calcium and D. For each 10 nanogram per deciliter bump in vitamin D with supplementation, there's a 35% relative risk reduction with respect to new onset of cancer. So vitamin D prevents cancer in this study. Now, let's extrapolate this to the entire population. Let's say everybody took vitamin D. Would that lower cancer risk by 35% across the board? Well, it might. It certainly would do something positive. We should be doing this. The closer you live to the equator, the greater will be your vitamin D levels and physiology. The lower is your risk for autoimmune disease, including multiple sclerosis. The lower is your risk of cardiovascular disease. The lower is your risk of cancer. You might have more skin cancers if you live close to the equator, but skin cancer is easy to treat. Your risk for deep internal organ cancers, which are more difficult to treat, is definitely lessened with the more sun exposure, the more vitamin D. Vitamin D promotes tolerance. When a cell of the innate immune system, an antigen capture cell, phagocytoses a microbe, chops the protein up into little pieces, it hightails it to the nearest lymph organ to initiate an immune response. In this process, it's transforming itself from an antigen capture cell to an antigen presenting cell armed with stimulatory cofactors. Vitamin D arrests this development such that the antigen presenting cell is tolerogenic. So this will promote tolerance within our immune system, and that will decrease our risk for allergy and autoimmunity. Thus, vitamin D is of value in cardiovascular disease, which involves an inappropriate Th1, Th17 immune response to antigenic determinants within the artery wall and within the myocardium, and the same thing in all the autoimmune diseases when we're mistaking altered normal proteins as foreign and mounting an immune response. Thus, vitamin D is going to be helpful in cardiovascular disease and in autoimmune conditions. Vitamin K, this is kind of a fun section. Vitamin K was first described in 1935 as the coagulation vitamin, thus vitamin K. There was a bleeding disorder in cholesterol deficient chickens. Now, vitamin K is fat soluble. If you are cholesterol deficient, you cannot transport vitamin K to the periphery. Vitamin K is transported in lipids, triglycerides, and LDL. So these chickens were not only cholesterol deficient, they were K deficient, they had a bleeding disorder. And a bleeding disorder was described in cattle in Wisconsin that were eating red clover. And red clover contains warfarin, or Coumadin is the trade name, and the name warfarin comes from Wisconsin Agricultural Research Farm, where this phenomenon was identified. Now, in 1939, two forms of vitamin K were isolated. K1 is phyloquinone. We get it from green leafy vegetables. It's not very well absorbed. We need 100 mics a day for abnormal clotting. Many Americans are below the RDA. K2 is minoquinone. We take in about 15 mics a day. We get it from meat, dairy, and the Japanese get it from a fermented soybean dish called natto. It's well absorbed. And we can also recycle, we can convert K1 to K2 and back and forth. So if we only get K1, we will make some K2, but we also are supposed to be getting K2 from our diet. And the biologically active form of K2 is important for vascular and bone health. K1 and K2 are fat soluble. They're transported in triglycerides and lipids. In 1941, warfarin was put into use as a vitamin K antagonist. It's isolated from red clover, and warfarin will block K1 recycling and create K1 deficiency, and then we cannot activate clotting factors, and that's why we use warfarin, or the trade name Coumadin, as an anticoagulant. Controlled poisoning, blocking the recycling of vitamin K, so we cannot activate clotting factors. Thus, we have a therapeutic anticoagulant effect. In the 1950s, a number of vitamin K-dependent enzyme systems were discovered that are necessary to promote coagulation and to control coagulation. So to promote coagulation, we have factor 2, factor 7, factor 9, factor 10. And then to control coagulation, to prevent pathological clot formation, we have protein C, protein S, and protein Z. Now, these factors are generated in an inactive form, unable to bind calcium. The clotting factors cannot function without calcium binding. Vitamin K is required for activation. Vitamin K adds a carboxyl group to glutamate in the clotting factor to form carboxylated glutamate called GLA. Clotting factors with GLA that have been carboxylated can bind calcium and function. So the nascent clotting factors generated in the liver cannot function if they're not carboxylated. They depend upon K1 to carboxylate them to GLA. The clotting factor with GLA can bind calcium and function. So we can convert K1 into K2 and vice versa. We don't take in much K1 and K2, but we recycle it avidly. So we don't need much in the diet as long as we can recycle it. Vitamin K1 and K2 are recycled 2,000 times. Warfarin blocks K recycling. No carboxylation, impaired clotting. So if our patients are taking warfarin, this is a controlled poisoning. We're blocking K1 recycling, so the clotting factors cannot be carboxylated, they cannot bind calcium, they cannot be activated, thus we get a therapeutic anticoagulant effect. And of course, then there can be no vitamin K supplementation, avoid vitamin K in the diet, or have a steady level of vitamin K intake, frequent monitoring of the PT-INR, because our patients will from time to time vary their diet, and if you're taking warfarin at a stable dose and all of a sudden you're taking a lot of green leafy vegetables, then your INR will fall, your blood will become thin. Conversely, if you've been taking a steady intake of vegetables and we balance that with a warfarin dose, and then all of a sudden you cold turkey, stop taking in the green vegetables, then your INR will rise and you're at risk for bleeding complications, which is why we don't like using warfarin. We're delighted that we have the new fixed dose agents, but warfarin works by blocking K1 recycling. We cannot activate the clotting factors, creating a therapeutic anticoagulant effect. What about K2? In 1970, fetal warfarin syndrome was noted. So if you're carrying a child and you're taking warfarin, that child will be born with bone and cartilage deformities. In animals placed on warfarin plus K1, there's normal clotting because the warfarin is blocking K1 recycling. Well, you can compensate for that with extra K1 so you don't bleed, but bones are deformed. In 1984, it was shown that osteoporotics with hip fractures have K1 levels less than 30% of that of healthy controls. Osteoporotics with vertebral compression fracture have a K1 level less than 25% of that of controls. Low K intake increases risk of osteoporosis and fracture. Osteocalcin, the activated carboxylated form, fixes calcium to bone. But if it's not carboxylated, it cannot fix calcium to bone. Thus, you're going to get osteoporosis. Uncarboxylated osteocalcin relates to osteoporosis and fracture risk. It's associated with low vitamin K intake. It's associated with warfarin anticoagulation because you cannot recycle your K1. It's responsive to K1 supplementation. In the 80s, in animal models where the animals were treated with warfarin, not only was their blood thinned, but they developed hypertension and vascular calcification. In 1983, matrix GLA protein was identified. This is a K2-dependent enzyme that is the most potent inhibitor of ectopic calcification. In 1997, they showed that MGP double knockout mice died 8 weeks of vascular calcification and vessel rupture. In 1982, it was shown that warfarin increases the rate of vascular and valve calcification. So if we treat our patients with warfarin, we are providing a therapeutic anticoagulant effect. We're wiping out K1. We're also wiping out K2. K2's job is to promote bone calcification and to prevent vascular and valve and joint calcification. The more calcification you have, the greater will be your expression of matrix GLA protein. The greater is your relative requirement for vitamin K2. So if you have extensive vascular calcification, you need more K2 than would a normal individual, and warfarin increases the rate of vascular and valve calcification. In 1995, it was shown that low K intake in humans increases risk of vascular calcification. The 2001 Rotterdam study showed that individuals in the upper tercile for K2 intake, 41 mics versus 15 mics per day, this was associated with a 50% reduction in calcification, vascular calcification, heart attack, and death. So we need K2 to prevent vascular calcification. If we don't get enough K2, we're going to have increased vascular calcification, increased cardiovascular event rate. And the greater the degree of calcification you have, the more K2 you need. We don't know what the best dose is. You can take up to 35 milligrams, and there's no downside. If we wanted to pick a dose for primary prevention, we would say 41 micrograms because that was the level that was associated with the level of K2 intake from diet that was associated with a decreased risk. And this was done in Europe. And where do we get our K2? From meat and dairy. That is, if the animals eat grass, if the animals eat corn, you don't get any K2. But this is another part of the French paradox. Meat and cheese from animals that were grazed on grass give us K2, prevent vascular calcification, decreasing cardiovascular event risk. So we've got these vitamin K dependent GLA proteins that they are throughout the body, and they have different roles to promote coagulation, to control coagulation, order calcification, and to inhibit ectopic calcification. If you have vascular valve calcification, matrix GLA protein is induced. If it is not carboxylated with K2, it will promote progressive calcification. If it is carboxylated with K2, it will inhibit progressive calcification. The RDA is designed to meet the K1 requirements for clotting proteins. We need more than that. K1 supplementation has been shown to decrease cancer risk. Many Americans are below the RDA for vitamin K. Osteocalcin and matrix GLA protein are more sensitive to vitamin K2 than K1 deficiency. K2 deficiency, osteoporosis, and cardiovascular calcification. Here is an animal model. This is sort of difficult to follow, but it shows that warfarin leads to vascular calcification via the mechanism of K2 deficiency. So we're going to take 10-week-old genetically normal rats. The control group gets a vitamin K deficient rat chow, but that situation is rectified with vitamin K1 supplementation with food. So this is the control group getting adequate K1. The warfarin and K rats chow with warfarin and a small dose of K1 but not K2. Then the low K1 rescue group, they're on the same diet with chow with warfarin and a low degree of K1. Then you stop the warfarin, so you're going to stop depleting the K1, and then you're going to give them 5 micrograms per gram food of K1. The high K1 rescue, they were rendered K1, K2 deficient with the chow diet supplement with warfarin. You stop the warfarin, you give them a higher dose of K1. The third group, you stop the warfarin, and instead of K1, you give them K2. Now, some of this K1 is going to go into K2, but if you supplement directly with K2, you're going to get a greater improvement in K2 physiology. Aortic calcification developed with warfarin and low-dose K1. It was progressive. You know, if you have coronary calcification and we repeat it every year, we expect it to progress inevitably. And some of that has to do with K2 deficiency. The more calcification you have, the more matrix GLA protein will be elaborated, the greater is your relative need for K2 supplementation. So in the group that got the low K1 and the high K1 rescue, there was a reversal of calcification, and the same with K2. Cellular apoptosis occurred because these calcified sick cells were dying. This was blunted with K1 and particularly with K2. Vascular distensibility, elasticity was compromised because the vessels are getting calcified, and you can rescue that with K1 and K2. Now, vascular wall matrix GLA protein. So the matrix GLA protein, if it is carboxylated, that prevents calcification. If it's uncarboxylated, it promotes calcification. So we treat these animals with warfarin. We're promoting calcification. We're getting more total matrix GLA protein, and most of it was uncarboxylated. So if we rescue with K1 and particularly K2, we will see a greater representation of carboxylated as opposed to uncarboxylated matrix GLA protein, and that would promote regression of vascular calcification that was brought on by K1, K2 deficiency due to warfarin administration. So here we have the control diet, warfarin and K1, we have calcification, low K1 rescue, high K1 rescue. The best result was K2 rescue in blunting vascular calcification. Here we have warfarin, 3 milligrams with a day, and K1, 1.5 milligrams daily over 4 weeks. Here we have warfarin, 3 milligrams a day, and K2, 1.5 milligrams over 4 weeks. We see a more prominent regression of vascular calcification with direct K2 supplementation. Some of the K1 will go into K2, but direct supplementation will greater increase K2 levels in vascular calcification. Vitamin K2 in hyperlipidemia. Patients with kidney failure on dialysis are at an increased risk for osteoporosis, ectopic calcification. They calcify their vessels rapidly. Hyperlipidemia, hypercoagulability, 10 to 20-fold increased cardiovascular risk. So we're going to take 17 renal patients on peritoneal dialysis, baseline lipid panel, and treat them with 45 milligrams, not micrograms, but 45 milligrams of K2. We're going to repeat the lipid panel at 7 months. No change in triglycerides, no change in HDL. Cholesterol fell from 250 to 186, LDL from 223 to 177. I do not know the mechanism through which K2 will lower lipids in this patient population. I've not seen this analysis in other populations, but this, of course, would have a favorable effect. Vitamin K and arterial stiffness. This paper is 10 years old. I imagine there are more recent papers that demonstrate benefits of vitamin K in arterial stiffness. Here, we're going to take 100 50-60-year-old women, 2 years into menopause, normal carotid ultrasound. You're going to record pulse pressure, do a carotid ultrasound, and look at distensibility, compliance, and something called Young's modulus, which has to do with vascular elasticity. Randomized to receive over 3 years placebo, minerals plus D, minerals plus D, plus a milligram of K1. They didn't give K2, but by giving K1, you're going to convert some of that into K2. Double-blind protocol followed. This is difficult to follow, but with placebo therapy, there was decreased distensibility and compliance. The pulse pressure was high, which is consistent with having stiff pipes, and a high level of Young's modulus, which is a marker of arterial stiffness. With minerals and D, there was some improvement, but minerals and D with K they improved, compliance improved, and the other markers returned to baseline. So minerals in D are helpful. Minerals in D and K1 are even more helpful. And if they had given K2, they probably would have had a better effect on arterial stiffness. So vitamin K2 is needed to prevent vascular calcification, to prevent cardiac valve calcification. We're never going to have a randomized double-blind study where you try to induce vascular calcification with warfarin and see if you can prevent it with K2. But some epidemiologic studies have been done where they took people with early valve disease, some on warfarin, some not on warfarin, and those on warfarin progress more readily. And I think I've seen this myself. I'll have a patient with severe mitral regurg and myocardial insufficiency, and they would require a St. Jude's prosthetic mitral valve. And with the St. Jude's valve, you have to be on warfarin the rest of your life. And I've observed that the aortic valves seem to go bad quickly, quicker than you would expect, and then they need a second valve surgery. And it's probable that the warfarin we're using is promoting valve calcification and valve failure. We need K2 to prevent arterial stiffness and hypertension. It's involved in bone metabolism and prevention of osteoporosis, cartilage metabolism and arthritis. The preventative dose in the Rotterdam study was 45 mics a day. We don't know what the best dose is. We really can't measure this. As a general rule, the greater the degree of pre-existent vascular calcification, the more K2 you need. So 45 mics is the preventative dose. 100 mics if you have early disease, 1,000 mics with advanced disease. You can go up to 35 milligrams a day. And these studies have been done, and there's no downside of K2. If you take high doses of K2, your bones just get stronger. Can we supplement with K2 when our patients are receiving warfarin? Now, in theory, that would be a good idea. The warfarin is blocking the recycling of K1. We don't care about K2. It's not involved in clotting factors. So why not concomitantly supplement with K2 when your patients are on warfarin? I actually think this is a bad idea because warfarin will block the recycling of K1 and the recycling of K2. So if we supplement with K2, we're going to use up some of the warfarin. Also, if we supplement with K2, some of that will go back into K1, and then you need more warfarin. So when this concept first came out 10 years ago, I took a handful of my own personal patients who were on a stable dose of warfarin. And for 3 days in a row, they took 100 micrograms of K2. And I checked their INR every day, and their INRs fell. Thus, if I was to keep them on K2, I would have had to increase their warfarin dose, and that warfarin would have then chewed up some of the K1 and K2, and I don't think we're going to have any net gain in vascular calcification if we supplement our warfarin-treated patients with K2. Now, others disagree with me, and they think that it's a good idea, but I would be very, very careful if you do this. I had a patient, a healthcare provider, who reads avidly about ways of promoting his own health, and I had him on warfarin. He had had a bypass surgery and a prosthetic valve, and he was in atrial fib. So he's on warfarin. So he decides to go on K2, and he doesn't tell me. He just forgets to tell me. And then, of course, I had to increase his warfarin dose because some of the K2 went into K1 and lowered his INR, so I compensate by increasing the warfarin dose. Then he was hospitalized for some non-cardiac reason. And when he got out of the hospital, you know how all of your treatments are altered when you're in the hospital. He forgot to go back on his K2. He stayed on warfarin. His INR skyrocketed and he bled. So if your patient is taking K2, you and the patient need to be on the same page. If you're going to try this maneuver, taking K2 along with warfarin, everything has to be on a steady dose, but I actually think it's a bad idea. And of course, in most of our patients, we can switch to the non-warfarin fixed dose agents that have nothing to do with K2, and that's what we're doing right now. The only patients who must stay on warfarin are those with metallic prosthetic valves, such as St. Jude's valve. One of the benefits of the newer agents is they have a short half-life. So they work, and then you have a trough level where you're not, when you're able to clot a little bit. And that's why the bleeding risk is less with the newer agents than with the warfarin, which is 365 days a year anticoagulation. But if you have a prosthetic valve, you cannot have that trough region because that plastic valve is so coagulable. So in all other situations where we would use warfarin, we can switch our patient to the newer agent, then we don't have to worry about K2 depletion. The only exception is if you have a St. Jude's or other non-biological prosthetic valve. Lipoprotein A. Lipoprotein A is ignored in allopathic cardiology because we have no drugs that will lower lipoprotein A or neutralize its atherogenic. What is lipoprotein A? It is LDL bound to an apolipoprotein a particle, and the apolipoprotein a particle acts as a Velcro strip, rendering LDL more sticky to bind to the artery wall and promote clot formation and plaque formation. Let's look at lipoprotein A and plaque inflammation. 72 patients undergoing percutaneous atherectomy, 26 with stable angina, 18 with unstable angina, 28 with rest angina. Evaluate plaque specimens for the presence of lipoprotein A. As you go from stable to unstable to red hot angina, you see a greater representation of lipoprotein A within the plaque. You see a lower representation of smooth muscle and a greater representation of macrophages. Within the inflamed unstable plaque, we have T cells releasing interferon gamma, clearing out the smooth muscle, rendering the fibrous plaque less resilient to plaque activation. So we have inflammation, we have T cells, we have macrophages, less smooth muscle, and lots of lipoprotein A, oxidized lipoprotein A, which is playing a role in plaque activation. If lipoprotein A co-localizes with the macrophages and the T cells, it does not co-localize with the smooth muscle because smooth muscle is being cleared out by interferon gamma in the region of the plaque that is active. You see a greater degree of lipoprotein A macrophage overlap as you go from stable to unstable to rest pain. So how do we deal with lipoprotein A? There are no drugs that will lower lipoprotein A or neutralize lipoprotein A because lipoprotein A is under genetic control. According to Linus Pauling, who won the Nobel Prize twice, and we'll listen to Dr. Pauling because no cardiologist has ever won the Nobel Prize. His theory is that mankind was dying of blood loss anemia during the Ice Age. During the Ice Age, we had less fruits and vegetables, less vitamin C. We need vitamin C to carboxylate lysine and proline to render collagen functional. So without vitamin C, we're going to get scurvy, we're going to get blood loss. So mankind was dying of scurvy. Thus, there was a beneficial mutation in the genetic code to make apolipoprotein a to create LPA, and its job is to plug the dike. Now, lipoprotein A will bind to exposed lysine and proline within the vascular wall. So if you have an artery that is damaged by scurvy, the lysine and proline will be exposed, lipoprotein will bind to it and will promote clot formation, and it will bring in LDL to repair the artery. And when vitamin C is then available in the diet, the lipoprotein A patch will swim out. That is its job in health. So many of us will have high lipoprotein A levels because it was adaptive to mankind when we are vitamin C deficient. When we have adequate vitamin C, the vessels are not damaged, lipoprotein A will not bind to the artery wall, it is not pathologic. But as it turns out, lipoprotein A cannot differentiate between an artery that is cracked or damaged due to vitamin C deficiency and an artery that contains plaque. So it binds to lysine and proline within the damaged vessel wall, particularly in areas with pre-existing atherosclerosis, and it sort of piles on, and it's intensely atherogenic. When you see new patients who are having recurrent cardiovascular problems, they've seen 3 different cardiologists. One thing you look at is lipoprotein A. They're all going to have a high LPA that's not been addressed. That's why statin therapies and ACE inhibitors and beta blockers alone didn't get the job done, because LPA was not addressed, particularly in young men. You'll see high lipoprotein A's, and you'll treat that lipoprotein A, and you'll improve their outcome. So you're not going to lower the level because it's under genetic control. Levels will rise with hypothyroidism, trans fat intake, and statins. So if you put your patient on a statin, their lipoprotein A level will rise. This was first pointed out by my friend and colleague, Dr. Steven Sinatra, and nobody wanted to believe him because we never want to hear about anything that's negative about statins, but statins will raise LPA. Now, a high LPA in relation to statin therapy probably does not have the same negative prognostic significance as a high native LPA, but you will see a bump in LPA when your patients take statins. Levels will fall with fish oil, probably niacin, estradiol in women, testosterone in men. So what we want to do, though, we're not going to worry about the level because not too many, it's going to bounce around on its own, and don't chase the level, but you can neutralize lipoprotein with vitamin C, lysine, and proline. So we're going to block attachment to the vascular wall with vitamin C. If we take vitamin C, we are going to have a more resilient elastic vascular wall, and we're going to hydroxylate the lysine and proline binding sites on collagen within the vascular wall so the LPA can't bind. So for every 10 milligrams per deciliter of LPA, and that would be on the 0 to 30 scale, with 30 being the 90th percentile. Different labs have normal effort ranges, but on the 0 to 30 scale, I'm going to give you 1,000 milligrams of vitamin C for every 10 milligrams of LPA. And then I have all my patients with high LPA take lysine 1,000 and proline 500 twice a day. That is my cocktail based upon the work of Linus Pauling, and it sure seems to work. Now, my evidence is in the days of balloon angioplasty, the restenosis rate was 50%, 60 to 70% in the LAD. So these patients were going balloon angioplasty repetitively. We called it the restenosis cycle. And then I found that they all had high LPAs. I put them on lysine, proline, and vitamin C. All of a sudden, they stopped restenosing. So if you have a high LPA and you undergo balloon angioplasty, your odds of restenosis are 5 to 10-fold greater than it is with low LPA because the balloon angioplasty produces vascular trauma, lysine and proline is exposed, the LPA rushes into repair, the repair mediates restenosis. Now, if you are going to have a balloon angioplasty and we measure your LPA level the day before and 2 days after the angioplasty, your LPA level will drop, because it's all rushing into the plaque and then you'll restenose. So patients with angina, particularly patients undergoing balloon angioplasty, I would treat them, they would get better. Now, most of the time, you can't really measure the benefit of LPA, but you'll find that over time it may reduce angina, but I really think it's improving outcome in our patients. Vitamin C, lysine, and proline are inexpensive, no downside, so that's my recommendation for LPA. Enhanced exerter counterpulsation. I have a good story as to how I became the 18th physician in the United States and the second physician in Ohio to get involved in EECP well over 20 years ago before I had any gray hair. Now, I had gotten involved in chelation therapy because patients went behind my back, got chelation therapy, and got better. I got to know Dr. Chappell. Then my very first patient, I've been taking care of her since the beginning of my career, and her bypasses had closed, her angioplasty sites had closed, she'd restenosed, she'd had a couple heart attacks, she was in heart failure, and there was nothing left but a heart transplantation. So we had her on the transplant list. Back then, you waited a long time for a new heart, and most patients died while they were in line. So she came to me and said, I want you to treat me with chelation therapy. And I said, gee, I don't know how. I understand it's a good idea. Go see Dr. Chappell. She goes, nope, I'm too sick to go. Plus, you owe it to me. And I go, well, what do you mean? I'm going to have to go take the course, spend a lot of money, getting the equipment. She goes, well, how much money did you make doing those 5 heart caths that didn't work? So she had me. So I called Dr. Chappell, and it so happened there was a course, and that was the one that was chaired by Dr. Rose, and I learned all about chelation therapy. And she was the very first person I treated, and she stabilized and got her heart transplant. And I would call that integrative cardiology, using chelation therapy to stabilize a patient so they can get a heart transplant. So I began to offer chelation to other patients with inoperable recurrent coronary disease, and it was really cool. We were taking people out of the restenosis cycle. They were getting better. We were making a huge difference. This was great. And then the medical board came and politely threatened me and said that I was at risk of losing my license if I continued to treat patients with chelation therapy. So what am I going to do? I could protect myself and drop out of chelation therapy, but then the patients would die or return to a cycle of repetitive procedures. Or I could stand firm and fight the medical board and take care of my patients. But if I lost my license, I'm maybe 40 years old then, my kids are still in grade school and junior high. If I lost my license, I would be economically ruined. How would I ever educate my patients? What a dilemma. Do I take care of my family? Do I take care of my patients? What am I going to do? Well, I was very distraught, obviously, and that weekend I had a meeting. It was an oxidative medicine meeting, and I didn't really want to go to it because I had this trouble with the medical board, and I was so upset that when I was packing, I forgot a book to read on the plane. So on my way to the airport, I realized I don't have a book. My office was on the way to the airport. I stop at the office and grab some junk mail. So I'm reading junk mail on the plane, and I've come across this flyer for this new technique called EECP. And it's FDA approved. So there's not going to be a problem with the medical board. So I'm thinking, gee, if I have to back down on chelation, I won't be turning my patients out in the cold because I can treat them with EECP. I land in Anchorage, Alaska at 11 o'clock at night. I call the phone number on the brochure. The guy's still awake, so we start talking. A month later, I did a site visit at the site in Columbus that was doing EECP. A month after that, I got started with EECP. A couple years after that, I had the busiest EECP practice in North America, and I helped a lot of people and had a lot of fun with EECP. So I really need to thank the medical board of the state of Ohio for threatening me. Now I stood firm, and they backed down. They really weren't serious. They just wanted to shake me up. So I continue to provide my patients with chelation therapy, and I got involved in EECP a lot earlier than I otherwise would have. So thanks a lot to the medical board. But with EECP, what we do, we generate a collateral flow. We put these large pneumatic cuffs over your lower extremity. We are monitoring your EKG and your pulse wave velocity at the level of the finger. And what we do, we inflate the cuffs in diastole when the coronary arteries are open such they can receive a collateral flow, and we deflate the cuffs during systole. We're unloading the heart. So we're unloading the heart, decreasing the heart's workload, and in diastole, we're jamming blood under systolic pressure into the native arteries, and then we're opening up collaterals. So we're providing laminar flow to improve endothelial function. We're generating collaterals so we can provide a non-invasive revascularization. If you have one good artery to work with, you can generate collateral flow to the other vessels, and you will be angina-free, or we can dramatically attenuate angina, and we can prevent heart attack, because if the artery is already closed, but you have good collaterals, you will be protected against further injury. And of course, we can improve stress perfusion studies. And this was one of the articles published in the American College of Cardiology journal showing that perfusion improves with EECP and outcome improves. So at first we thought all we were doing is generating collaterals, but we found that outcome following EECP seems to improve. I kept records of all the patients we treated our first 3 years. I think it was 180 patients. And I looked at event rate 2 years pre-EECP and event rate 2 years post-EECP, and the natural history of their atherosclerosis was being altered. So not only were we relieving angina, we're having a favorable effect on biology. And what EECP does is it improves endothelial tone and has an antioxidant effect. Malondialdehyde, a marker of lipid oxidation akin to oxidized LDL. Here we did a study, or I didn't do the study, but another group did the study. Patients with angina, and you treat them with medications for 6 weeks, there's no change in malondialdehyde. Another group gets treated with EECP, their angina improves, malondialdehyde falls. Endothelial function triples. So if you have refractory angina, you have endothelial dysfunction, we treat you with EECP, we increase laminar flow, and we improve your physiology. We're going to upregulate NOS, and endothelial function improves. This is an animal model of a high oxidized cholesterol diet-induced atherosclerosis with or without EECP. They did pigs. I don't know how you do EECP on a pig, but they figured out a way of doing it. Mitogen activated protein kinase, one of the serine kinases that translocates nuclear factor kappa beta to the nucleus, was upregulated with the hyperlipidemic diet, because hyperlipidemia leads to endothelial dysfunction, leads to oxidative stress, inflammatory stress, MAPK expression increases, nuclear factor kappa beta translocation increases, more inflammatory cytokines. This was blunted with EECP because EECP generates nitric oxide. Nitric oxide will blunt nuclear factor kappa beta translocation. So the deleterious effects of the high oxidized cholesterol diet on nuclear factor kappa beta translocation was blunted with EECP via the mechanism of improved endothelial tone, improved elaboration of nitric oxide. And it worked very well on Aaron Rodgers, and we have to do a better job next year and get him back on the field so the Packers will at least advance into the first round of the playoffs. Now, let's talk about testosterone replacement therapy in men with cardiovascular disease. Testosterone deficiency underlies many of our other standard risk factors. Conversely, other pathophysiologic phenomena risk factors for cardiovascular disease, diabetes, inflammation, cortisol excess, leads to testosterone deficiency. In any event, low testosterone is associated with an increased cardiovascular risk in men. Over the past few years, there's been a lot of negative press regarding testosterone. If we analyze these reports, we will conclude that this is biologic fake news. Most of the negative reports were based on epidemiologic analysis. They will look at cardiovascular event rate 2 years before through 2 years after a man begins testosterone replacement therapy, and this would be for topical testosterone replacement therapy. And over the 2 years after you begin testosterone, your cardiovascular event rate is greater than over the 2 years before you began testosterone. So they would say, aha, testosterone deleterious. But this was not a randomized double-blind analysis. It's an epidemiologic analysis. The fact that you're going on testosterone means that you're older and you're sicker. Otherwise, you wouldn't go on testosterone. So the onset of testosterone replacement therapy is a sign of increased risk. It's the patient's natural history, not the testosterone. In addition, the testosterone was delivered via topical application of gels and creams, and that is how Big Pharma formulates testosterone replacement therapy. Now, the gonads release a trickle of hormones, testosterone, estradiol, progesterone, into the circulation. If we apply hormones to our skin, nothing happens because they're hydrophilic. To render the hormones absorbable, they must be rendered lipophilic in a cream or a gel. So we absorb these hormones through the skin, and then when they hit the circulation, these lipophilic hormones will bind to the red cell membrane. When we do blood levels, it's not a blood level, it's a serum level. We exclude the red cells. So the testosterone, if it's sticking onto the red cell, it's not in the serum level will underestimate the tissue effect, and then we will overdose the patient. So the downsides of topical hormones, for the most part, have to do with systemic overdosing. We cannot rely on serum levels. Instead, we need a cellular assessment, and that could be a 24-hour urine, a blood spot level where you prick your finger and bleed onto a piece of paper. They elute the blood, serum, and red cells from the paper and measure the level, or salivary levels. Here, the salivary glands are taking up the hormone, processing it, putting it in the saliva. So if we're going to use topical hormones, we should not rely on plasma levels. Otherwise, we're going to overdose the patient. Now, convincing other doctors and patients that these serum levels are not reflective of the tissue effect is very, very difficult. We all want to use serum levels. If we use the blood spot methods, the 24-hour urines, the salivary levels, the range is very, very high. We don't like that. We like to have narrow ranges to target our dosing. Insurance companies don't want to pay for these. So for the most part, in the United States, when we're using hormones, we're using them topically, and we're overdosing, and we're having adverse effects. If you look at transcription of pro-clotting versus anti-clotting factors, with physiologic testosterone, you get what you want. But with superphysiologic testosterone, you stop making anti-clotting factors, you make procoagulant factors. So topical testosterone overdose, because we're chasing serum levels rather than tissue levels, is kind of like giving younger professional athletes anabolic steroids. They love it, they feel great, but it's deleterious. Patients tend to feel better with superphysiologic levels. They like that, but that's deleterious. We need to be in the physiologic range. So I'm going to argue against topical. And if you use topical, use blood spot or salivary or urine levels, 24-hour urine levels, and don't rely on plasma levels. In addition, we want testosterone. We don't want dihydrotestosterone. We don't want estradiol. 5-alpha reductase is expressed at a high level in the skin and subcutaneous fat. So for every unit of testosterone that we give topically, a greater percentage will be converted to dihydroxytestosterone. That doesn't help our mood. It doesn't help our arteries. It stimulates the prostate. Aromatase converts testosterone to estradiol. It is expressed in fat, belly fat particularly, and in subcutaneous fat. So we're going to be converting the testosterone to estradiol. Estradiol is clearly deleterious. Estradiol is a direct risk factor for cardiovascular disease. We want a high physiologic free testosterone level and a low physiologic estradiol level. One of the negative testosterone studies, called the TOM study, was published in the New England Journal of Medicine 5 years ago. They took old, obese men and used topical testosterone. And over 2 years, cardiovascular event rate increased, and they didn't even bother to measure estradiol. So if we have older men who are overweight with high expression of aromatase, we give them topical testosterone, it all goes into estradiol. Of course, we're going to have an increased adverse event rate because we're causing estrogen excess. Why the editors of the New England Journal of Medicine published this article, I don't know. It's because most American physicians don't understand that when we give a hormone, it will be converted to downstream metabolites. So we want testosterone. We don't want dihydroxytestosterone. We don't want estradiol. Thus, if we're going to use testosterone, I favor parenteral testosterone. I like to place pellets under the skin. I get a fairly steady level over 6 months. There's a slight peak and a trough, but I'm mostly in the physiologic range. If we're going to do injection, we used to give one big dose once a month because that was convenient. That's a very bad idea. You get a peak and then you get a trough. When you're peaking, you're going to convert more of the testosterone to dihydroxytestosterone and estradiol. Then you have the trough where you're not having a therapeutic effect. So now if you're going to do IM testosterone, low doses, 2 to 3 times a week, then there's less of a peak and trough effect. So I think that the negative effects of testosterone have to do with the delivery system and American physicians not dosing testosterone properly and not paying attention to conversion to dihydroxytestosterone and to estradiol. But I think that parenteral testosterone has much more good to offer than downside. Low testosterone is linked to a number of adverse physiologic phenomena that increase our cardiovascular risk, and they're all listed here. Pertinent to my interest in inflammation and immune dysregulation, low testosterone leads to abnormal inflammation and the elaboration of Th1 and Th17 cytokines and a decrease in the elaboration of Treg tolerogenic cytokines. Now, testosterone inhibits nuclear factor kappa beta translocation. That's all you need to know that testosterone is going to lower inflammation. Testosterone decreases the generation of IL-6, IL-1 beta, CRP. It increases the transcription of the regulatory cytokine, the Treg cytokine, IL-10. It decreases endothelial adhesion molecules, VCAM and ICAM, and decreases matrix metalloproteinase activity. Now, matrix metalloproteinase is the stuff that degrades the fibrous plaque and helps convert a stable plaque into an unstable plaque. Cytokines are the driving force in atherosclerosis, and atherosclerosis and heart failure are associated with a skewed, imbalanced immune response favoring Th1 and Th17 cytokines. Conversely, Th2 and Treg phenomenon are attenuated. So let's look at the effect of testosterone and cytokine levels in 69 men with angiographically proven coronary disease. Some had single vessel disease, some had 2 vessel disease, some had 3 vessel disease. And you evaluate their testosterone status. Hypogonadal was if their total testosterone below 7.5, borderline is 7.5 to 12, eugonadal is above 12. Some were low, some were borderline, some had normal testosterone physiology. You'll measure inflammatory cytokines, TNF-alpha, interleukin-1 beta, IL-6, all products of nuclear factor kappa beta translocation, and the anti-inflammatory Treg cytokine IL-10, a good guy. Look for correlations and relationships. As we go from 1, 2 to 3 vessel disease, we see in lockstep an increase in the expression of interleukin-1 beta. Interleukin-1 beta is an inflammatory cytokine. It is involved in plaque proliferation, endothelial dysfunction, plaque destabilization. This makes sense. Interleukin-6 was elevated in 3 vessel disease versus 1 and 2 vessel disease. IL-10 also rose. Now at first this doesn't make sense because IL-10 is a regulatory cytokine. Why would IL-10 be greater in the patient with 3 vessel disease? Well, these patients were all stable. When Mother Nature initiates an inflammatory pathway, such as Th1, Th17 cytokines, she's also going to kick in a compensatory regulatory phenomenon, so IL-10 levels will rise as a compensatory phenomenon. If you repeated this analysis in people with unstable angina, where you've got an out-of-control immune response, maladaptive immune response, you would see less IL-10. Loss of IL-10 creating an imbalance between too much Th1, not Treg, would be associated with an unstable plaque. and these patients were stable. The reason IL-10 rose, it was Mother Nature compensating for too much interleukin-1 beta, interleukin-6. So in other words, we see more inflammatory cytokines as we go from 1 to 2 to 3 vessel disease, and in stable patients, we see a compensatory increase in the Treg cytokine IL-10. So we look at as we go from 1, 2 to 3 vessel disease, we see a rise in interleukin-1 beta. As we go from normal testosterone to borderline to low testosterone, we also see a rise in interleukin-1 beta, which is cause, which is effect. We see an association between the extent of coronary disease and the elaboration of Th1 cytokines. And again, which came first, the coronary disease or the immune dysregulation? In truth, coronary disease leads to immune dysregulation. Immune dysregulation leads to more coronary disease. Can we intervene? If we have inflammation, if we have a high CRP, and we intervene with testosterone, can we lower inflammation, lower CRP? 60 middle-aged to elderly men, they were presenting to a clinic with urologic complaints, not cardiovascular complaints. They were all hypogonadal. You measure baseline CRP and a scale of the degree of testosterone deficiency, the AMS, Aging Male Symptom Scale. Treat all with testosterone undecanoate, 1,000 milligrams IM every 12 weeks. Reevaluate at 12 months. Their hypogonadal symptom scores fell with testosterone replacement therapy, as did C-reactive protein. At baseline, the more hypogonadal you were experiencing, the more symptoms of low testosterone you were experiencing, the greater the AMS score, correlated with a higher CRP. And the improvement in your symptoms with testosterone correlated with a drop in CRP. So hypogonadal men are experiencing inflammation. Much of the symptomatology of hypogonadism is due to excessive inflammation. If you replete testosterone, you improve symptomatic status, and one of the mechanisms is that you lower inflammation, and that would be manifested by a reduction in CRP. Another study of testosterone inflammation, 25 men attending an outpatient andrology clinic, 20 with coronary disease, 2 with heart failure, 10 with hypertension, 9 with type 2 diabetes, do the baseline lab studies, randomized to receive on days 1, 14, and 28 testosterone ester, Cestinon, 100 milligrams IM, or placebo. You're going to repeat the lab studies on day 30, then following a 30-day washout period, cross over to the opposite regimen. So every subject was treated with placebo or testosterone. This was a randomized, single-blind crossover protocol that was followed. With placebo therapy, testosterone does not rise. With testosterone replacement therapy, it rises, of course. TNF-alpha rises with placebo therapy. It falls with testosterone therapy. Interleukin-1 beta rises with placebo. It falls with testosterone. IL-10 falls. That's the Treg cytokine. That's desirable. It rises. Now, let's look at an in vitro study showing how testosterone will blunt nuclear factor kappa beta translocation. We're going to use human umbilical vein endothelial cells, HUVECs, in tissue culture, measure levels of tissue factor pathway inhibitor, messenger RNA. So we're going to look at the product of transcription and the product of translation and nuclear factor kappa beta translocation. Now, tissue factor promotes clotting. Tissue factor pathway inhibitor would inhibit clotting. Before and after incubation with testosterone or the Th1 cytokine tumor necrosis factor alpha, which would initiate nuclear factor kappa beta translocation, TNF stimulation with testosterone pretreatment. Tissue factor pathway inhibitor that would have an anti-clotting effect, the protein expression and the messenger RNA transcription rises with testosterone. It's blunted with the Th1 cytokine TNF-alpha. But that inhibition of tissue factor pathway inhibitor transcription and expression brought on by tumor necrosis factor alpha, because it's translocating nuclear factor kappa beta nucleus, is blunted with testosterone. Nuclear factor kappa beta DNA binding is blunted with testosterone. It has a tonic anti-inflammatory effect. It is, of course, increased with TNF-alpha, and it's blunted with testosterone. So as we age, we lose testosterone. Our ability to keep nuclear factor kappa beta in check declines. Just as if you can't make nitric oxide, you can't keep nuclear factor kappa beta in jail. If you don't have testosterone, you don't keep nuclear factor kappa beta in jail. It translocates to the nucleus. We can rectify that situation, and we can blunt the deleterious effects of inflammation on nuclear factor kappa beta translocation with treatment with testosterone. Testosterone and prostaglandin mix. Here, we're going to take 67-year-old men with a prior heart attack, measure testosterone, estradiol, prostacyclin, and thromboxane A2. Thromboxane A2 is an inflammatory procoagulant eicosanoid generated from arachidonic acid from meat and dairy. Prostacyclin would counterbalance that. We want high prostacyclin and relatively low thromboxane A2. We do the baseline measurements in these patients with coronary disease, then randomize them to a single intramuscular administration of saline or sustanon, which is sustained release testosterone. Repeat the labs at 3 weeks compared to levels drawn from healthy controls. So at baseline, the patient with cardiovascular disease had greater estradiol levels and lower testosterone levels than healthy controls. That's why they have cardiovascular disease. Low testosterone and high estradiol are atherogenic. So if you treat them with testosterone, you will see an uptick in estradiol, because when we administer testosterone, the enzyme aromatase will convert some of that into estradiol, particularly in overweight men, and that's deleterious. Now, what we would do, we would concomitantly administer anastrozole that blocks aromatase, so we would get an uptick in testosterone without an uptick in estradiol, but they didn't use that, so estradiol went up, but testosterone went up. The ratio of estradiol to testosterone, which would be deleterious, a bad sign, was greater at baseline in the men with heart disease than in the healthy controls. Why they had heart disease, and the ratio improved. And we could have done better with concomitant anastrozole therapy. Thromboxane A2, a deleterious eicosanoid, and prostacyclin, a beneficial eicosanoid, were lower in the patients than in the healthy controls. But in response to testosterone replacement therapy, we see a decrease in thromboxane and increase in prostacyclin. The ratio of thromboxane to prostacyclin, again, Mother Nature is doing everything not with absolute values, but with ratios. It was abnormally increased, and it improved with testosterone replacement therapy. So what are the effects of testosterone, parenteral testosterone, in men with cardiovascular disease? Angina frequency and severity decreases, nitroglycerin requirement decreases, time to ST depression, treadmill time, ischemic frequency on a 24-hour Holter monitor, signs of heart failure, symptoms of claudication decrease, wound healing, energy level, sense of well-being, depression, bone mineral density, muscle strength, memory, erectile dysfunction, bladder function, all improve. On my website, there is a 4-hour DVD presentation. Basically, I'm reciting all the literature on testosterone as of 10 years ago, and I present all these studies and more, and you're certainly encouraged to look at all that information. Lumbrokinase in atherosclerosis. Will an extract of earthworm, the earth dragon, help our patients with cardiovascular disease? And again, there's an hour on lumbrokinase on my website, heartfixer.com. Now, earthworm is D-long, the earth dragon, and it's traditionally used in medicine and as a food resource in China. The traditional Eastern world's pharmacopoeia, the Ben Cao Gang Mu, describes lumbrokinase as potent medicine for liver wind uprising and channel blockage conditions. And of course, there's a whole Eastern medicine, Chinese medicine science where they have these descriptions for imbalances in our body, and whatever is involved with liver wind uprising and channel blockage, and I presume that refers to cardiovascular disease, may improve with lumbrokinase. D-long, or earthworms, are used to treat inflammatory, hematologic, oxidative, and nerve diseases in the Orient. And lumbrokinase is a fibrinolytic enzyme released by the earthworm to digest foliage so the earthworm can make forward progress. So there's all these fibrinolytic enzymes, and it's secreted in all the organs of the earthworm, and some of the sections of the earthworm will elaborate greater degrees of lumbrokinase. So what you do, you would cut the earthworm into little pieces, put it on a plate that contains fibrin, Segments 5 and 6 are generating greater degrees of fibrinolytic enzymes because they're lysing the fibrin. So for commercial lumbrokinase production, they take these specific strains of earthworm, take specific sections, specific organs of the earthworm, and they harvest the lumbrokinase and they put it into a capsule form for to be used as a therapeutic supplement. Now, what will lumbrokinase do? It will directly degrade fibrinogen. And if we have less fibrinogen floating around, we are less likely to convert the fibrinogen into fibrin clot. It will also directly degrade fibrin. So lumbrokinase degrades fibrinogen, it degrades fibrin. Thus, it decreases the precursor for fibrin clot. And if you have a clot, it will be lysed by lumbrokinase. Lumbrokinase also increases tissue plasminogen activator to promote conversion of inactive plasminogen to plasmin, which also will lyse clots. And it decreases plasminogen activator inhibitor. So directly and indirectly, lumbrokinase will lyse clots and it will help prevent clots. Would this work in humans? 310 subjects with a carotid distribution ischemic event within the preceding 6 months. They had CVAs confirmed with CT or MRI studies their fibrinogen levels were above 200, or they had a carotid distribution TIA. So they had a CVA or a TIA. You're going to exclude patients with a hemorrhagic or embolic CVA, requirement for warfarin, planned surgery, those comatose at presentation, or those with advanced renal, liver, endocrine, or hematopoietic disease. So individuals who have a fairly good prognosis with a prior CVA or a TIA will lumbrokinase improve their outcome. Do baseline studies, randomized to receive over 1 year, lumbrokinase 600,000 units 3 times a day. We don't use lumbrokinase in this format, but I think this would be 2 capsules of lumbrokinase 3 times a day. You take it before a meal. If you take it with food, it'll be used up digesting the food, so you want to take it on an empty stomach and it's well absorbed. You get lumbro or you get placebo. Primary endpoint, all-cause mortality, recurrent CVA, hemorrhagic CVA, myocardial infarction, or non-cerebral ischemic or hemorrhagic event. This was a multi-center study. 11 hospitals were involved, randomized parallel group open label study. Mean age is 67 years, 88% completed the study. At baseline, 81% were on antiplatelet therapy, 30% on antihypertensives, 30% on statins. Over the course of 1 year, the medicines were pretty much held at the same dose. They were able to decrease antiplatelet and statin therapy in a minority of the patients. So what happens? PI1 promotes clotting. There was no effect with placebo therapy or lumbrokinase. TPA promotes the conversion of plasminogen into plasmin to increase our ability to lyse clots. It fell with placebo therapy, deleterious, and it rose with lumbrokinase. D-dimer fell. Now, D-dimer is created when we lyse a clot. So if you go into the emergency room with a suspected DVT or a PE and the D-dimer is high, that means that you have formed a clot, your body's beginning to lyse it. And that was increased with placebo therapy. It was decreased with lumbro. Stated otherwise, you are less likely to be forming clots, either microscopic clots or macroscopic clots in relation to if you were taking lumbrokinase therapy. Fibrinogen fell and blood viscosity fell. When fibrinogen is high, blood viscosity increases. That causes an abnormal shearing stress on the vascular wall. High viscosity is a risk factor for atherosclerosis. You lower fibrinogen, you lower viscosity with lumbrokinase. C-reactive protein fell in both groups, but it fell a little bit more in the lumbro group. No effect on PT, INR, or PTT. They were normal and unchanged in both groups. Non-vascular adverse events, 3% with lumbro, 6% with placebo, so no negative effects. Changes in plaque volume at 1 year. In the right carotid, plaque volume increased by 80% with placebo therapy. It decreased by 51% with lumbrokinase. Similar situation in left carotid. The findings of a hypoechoic plaque. This would be a non-fibrotic or more vulnerable plaque. So these ultrasound findings suggesting plaque vulnerability regressed in the lumbrokinase group. So the plaques are smaller. They appear, at least by ultrasound assessment, to be less vulnerable. carotid IMT progressed with placebo therapy as you would expect. It regressed with lumbrokinase. Anything that regresses IMT is favorable. So your plaque forming potential decreases, thus you get, instead of plaque progression, you get plaque regression. So in the placebo group, IMT increased. In the lumbrokinase group, it decreased. So your physiology improves, IMT falls, and you actually have macroscopic plaque regression with lumbrokinase monotherapy in patients who had experienced an ischemic TIA or stroke. So what effect is this going to have on outcome? As you would expect, the lumbro patients did better. Primary vascular event endpoints fell from 6.8% to 2.1%. Event-free survival was improved. Lumbrokinase in unstable angina. 20 patients admitted with red-hot unstable angina. Baseline measurements all received lumbrokinase 2 capsules 3 times over 10 to 14 days. Our standard dose is 2 capsules 3 times a day for 2 to 3 weeks. Then you go to 1 capsule 3 times a day. Repeat the baseline studies. This was a non-randomized open evaluation. There was no change in PT or PTT. Now, lumbrokinase does not deplete clotting factors. Warfarin will knock out vitamin K, so you can't make your normal clotting factors. The PT will rise. Heparin will raise the PTT. Lumbrokinase doesn't work that way. It doesn't degrade clotting factors. It does not increase your risk of bleeding. All it does is degrade fibrinogen and fibrin. So it won't promote bleeding. It just will inhibit abnormal clotting. So no change in PT or PTT. Lumbrokinase is not associated with an increased risk of hemorrhage, unlike clopidogrel, aspirin, or warfarin. No change in PT or PTT. C-reactive protein falls, there's less inflammation. Fibrinogen falls, less viscosity. Plasminogen falls because the lumbrokinase is converting plasminogen into plasmin. You would expect that plasmin would rise. It probably did early on, but at 2 weeks it's lower. Presumably the plasmin is being utilized lysing these clots. Platelet aggregation decreased in these patients with unstable angina. What was the effect on outcome and symptoms? If you look at the Chinese literature, they will use markedly effective, effective, and ineffective based upon signs and symptoms. Markedly effective was an 80% reduction in angina frequency and angina duration. Lumbrokinase was markedly effective in 50%. Ineffective was less than 50% reduction. Lumbrokinase was ineffective in only 20%. Total effective rate markedly and somewhat effective 80%. So lumbrokinase in unstable angina attenuates symptoms and it lowers C-reactive protein, it lowers fibrinogen, it encourages the conversion of plasminogen into plasmin, which will lyse fibrin clots, it will degrade fibrinogen, it will directly degrade fibrin and lyse clots, thus it's of value in unstable angina. What about lumbrokinase in chronic stable angina? 10 subjects with chronic stable angina, they're on medical therapy, none with prior thrombolytic therapy. 8 of the 10 had features of the metabolic syndrome, which of course is a hypercoagulable pathophysiology. Baseline measurements, they received lumbrokinase 500 milligrams 3 times a day. I think that would be 1 capsule 3 times a day using the units that we use in the United States. Repeat baseline measures. And they did stress perfusion studies before and after, and they rated the segments as normal, mildly abnormal, moderately abnormal, and severe. And they found that the sum stress score, the degree of ischemia, was greater at baseline and it attenuated with lumbrokinase. So perfusion improved, the sum stress scores moved more away from severe, and a few actually normalized. So perfusion was actually normalized in some of the segments when patients with chronic stable angina took lumbrokinase. They looked at the sum difference scores between stress and rest, and there was an improvement. So perfusion improved when patients with chronic stable angina were treated with lumbrokinase. So what was the clinical effect of lumbrokinase supplementation in patients with chronic stable angina? In 6 of the 10, perfusion improved with an amelioration of angina. In 1 of the 10, perfusion improved without a change in angina. Metabolic syndrome was present in all the subjects with improved perfusion versus only 1 of the 3 subjects without improved perfusion. They felt that metabolic syndrome was associated with a hypercoagulable state. increased elaboration of fibrinogen, therefore a greater upside potential, lowering fibrinogen and lysing fibrin in the patient with metabolic syndrome. Metabolic syndrome is associated with increased fibrinogen, increased viscosity, impaired fibrinolysis, increased platelet reactivity, and all these phenomenon are going to be attenuated with lumbrokinase, no adverse events, and no bleeding risk. Lumbrokinase physiologic effects: it directly degrades fibrinogen, viscosity falls. We want low viscosity. We want laminar stress, not oscillatory shearing stress. High viscosity compromises shearing stress against the artery wall in a deleterious fashion. So we want to lower fibrinogen to lower viscosity. It has a fibrinolytic effect. It will directly cleave fibrin. It will also activate TPA and inhibits PI1. This enhances plasminogen to plasmin conversion. Plasmin as well will degrade fibrin. So directly and indirectly, we have a fibrinolytic effect with lumbrokinase. Platelet aggregation is inhibited. There's an anti-inflammatory effect. Endothelial adhesion molecule elaboration decreases. IMT digresses. Plaque regresses. So lumbrokinase is a great clinical utility. Studies carried out in the Orient show benefit in ischemic cerebral infarction, and TIA, and central retinal venous occlusion, angina, unstable angina, post-infarction angina, what they describe as pulmonary heart disease. That paper was not translated. I think that probably means pulmonary hypertension, benefits in diabetes mellitus. I don't know if it improves sugar control, but probably blunts some of the inflammatory sequelae of diabetes. They talk about its benefit in chronic fatigue and fibromyalgia, which may involve microvascular clot formation. Thus, lumbrokinase therapy makes sense. Side effect potential is minimal to non-existent. We do not have abnormal clotting because we're not inhibiting clotting factors. All we're doing is lysing clots. Now, will it be effective in DVT prevention? This has not been studied. Logically, we wouldn't expect that lumbrokinase would. Its American cousin, nattokinase, will prevent DVTs. If you fly from New York to London, 10% of you will develop a blood clot. If we do ultrasounds before and after, there will be a subclinical clot in 10% of us. But if you take nattokinase at liftoff and halfway through, clot formation is attenuated. Now, I use lumbrokinase as opposed to natto because lumbro has a lot more literature, but they're both serine endopeptidases. They both promote fibrinolysis. So if nattokinase prevents DVT, lumbrokinase probably would. Will it work in atrial fib? So we've got this epidemic of atrial fib, and the thing we worry about the most is clot formation within the left atrial appendage. So we put you on blood thinners, and we pretty much put you on blood thinners the rest of your life. And then you have that bleeding risk. Well, there's no bleeding risk with lumbrokinase. Could we transition all of our patients from the fixed dose oral anticoagulants or warfarin to lumbrokinase? Would it work? Intuitively, we have predicted it would work, but we don't have any science. We have no studies to show that lumbro or nattokinase would work in chronic atrial fib, and I tell patients that. And I don't promote the use of lumbro or natto as an anticoagulant in atrial fib because we just don't know, and if we are wrong and you have a stroke, we certainly blew it. However, if a patient cannot take an oral anticoagulant because they have a bleeding risk, or if they absolutely refuse, I will use lumbrokinase. It's certainly better than doing nothing. But one caveat here is the half-life of lumbrokinase and nattokinase is relatively short, as opposed to the half-life of warfarin, which is relatively long. So if you're going to be taking lumbro or natto for DVT prevention, you got to take 2 to 3 doses a day. Taking 1 dose in the morning will provide you coverage for 8 to 12 hours, but not beyond that. So if you're going to use lumbro or natto to prevent DVT or to prophylax against clot formation atrial fib, it's really important to take 2 to 3 doses a day. The other problem is the rest of the medical world does not understand this. If the patient is hospitalized, they will be taken off their lumbro and natto, and then they will be at risk for clotting. If they're going to have an elective procedure and they're always told, stop all your supplements, well, then you would be taking away their anticoagulant preventative strategy. So I don't recommend lumbro over warfarin or fixed dose agents in the situation of atrial fib, but I will use it if the patient cannot take a fixed dose anticoagulant or warfarin, or if they absolutely refuse. We completed part 3 of our 5-part presentation with the discussion of lumbrokinase. obviously a valuable addition to our therapeutic armamentarium. Lumbrokinase is a standard therapy in the Orient, and because we are open-minded integrative practitioners, we can incorporate Oriental therapies and therapies utilized in other parts of the world into the integrative approach to cardiovascular medicine in relation to helping our patients in the United States. Part 4 begins with a discussion of berberine, also a standard therapy in the Orient that we can use to lower cholesterol, improve insulin insensitivity, deal with inflammation, and improve the outcome of our patients. So please move on to part 4.